Welcome back. We will now begin session 3 on insurance and ground ambulance payment systems with Asher Mikhail and Andrew Badarako.
Hi, thank you. My name's Asher Miko, and apologies for the voice. I have a little bit of a cold. And we had a bit of a scheduling sort of mix up. And so instead of Andrew Badarako, Richard Kimball will be presenting with me. And I'm a technical director in the financial management group at the Centers for Medicaid and CHIP Services. Richard Kimball is also a technical director in the financial management group, and will be presenting an overview of ways in which state Medicaid programs may pay for ground ambulance services provided to Medicaid beneficiaries. Next slide, please. State Medicaid programs are responsible for determining their ground ambulance payments, and those payments must comply with federal laws and regulations, some of which you see on the slide. Because Medicaid is a state-federal partnership, states must submit to CMS and get approval for payments authorized under state plan, managed care, or Section 1115A demonstration authority. Next slide, please. States can use different methodologies to pay for ground ambulance services, and these can include methodologies such as specifying the rate that will be paid, for example, a per transport rate, describing how to calculate a rate, for example, payment at a percentage of the current Medicare rate, and using a fee schedule that lists the rates that will be paid. Next slide, please. On these next 6 slides, I'll provide you an overview of how states may make reimbursement to providers for the actual and incurred cost of ground ambulance services that are provided to Medicaid beneficiaries. Cost reimbursement is another payment methodology that states can use to pay for emergency medical transportation services provided to Medicaid beneficiaries. All payment methodologies, including cost reimbursement, must be comprehensively described and include all information necessary for CMS to determine if the methodologies can serve as a basis for federal financial participation. In other words, if they can serve as the basis for federal funding. Next slide, please. The Medicaid state plan must describe payment methodologies for each of a state's Medicaid covered services. A methodology that reimburses for actual incurred costs must likewise comprehensively describe the cost identification and reconciliation methodologies that are used to determine a provider's payments. Next slide, please. A reimbursement methodology for ground ambulance services should describe the following: the interim rate that providers will be paid before cost settlement occurs, the allowable costs, both direct and indirect, that are associated with furnishing the services, the process for identifying and allocating Medicaid's portion of a provider's costs, and procedures and timing for the completion of the cost report by the provider, the submission of that cost report by the provider to the state, and when the cost reconciliation will be completed by the state, and when the payment will be made to the providers. Next slide, please. It is important to note that the state's cost identification and allocation procedures must comply with federal cost allocation regulations, which are implemented at 2 CFR Part 200 and 45 CFR Part 75. Next slide, please. While CMS reviews state cost reports before approving these payment methodologies, it is the states that are responsible for ensuring that reported costs and the associated claims for federal financial participation are accurate and represent only costs associated with the provision of Medicaid covered services to eligible Medicaid beneficiaries by qualified and enrolled Medicaid providers. Next slide, please. As I described on the previous slide, cost identification and allocation methodologies must only represent the cost associated with the provision of Medicaid covered services provided to eligible Medicaid beneficiaries. and they should not shift costs or allocate costs to the Medicaid program that are not related to a covered Medicaid service. It is also important to note that improperly claimed costs may be the subject of financial reviews and/or federal audit findings, which could place states at financial risk of having to repay the federal government's share of any overpayments that were identified. Thank you, and I'll turn things over to Richard, who will discuss supplemental payments.
Thank you. Next slide, please. Thanks, Asher. I'm Richard Kimball, also Financial Management Group, as Asher mentioned. I'm just going to talk a little bit about what's happened in the last decade or so. What we've been seeing is a considerable increase in the number of states that have proposed new supplemental payments for ground emergency medical transportation. And these are often targeted to local ambulance providers within various states for the services provided to Medicaid beneficiaries. A few supplemental payments made to qualifying private providers and ambulance services, but generally they're for public supplemental payments. The level of payment of a supplemental payment will often vary depending upon the state's selected methodology. States that elect to use cost reimbursement, as Asher was talking about, as the supplemental payment, they can do that. They pay the difference between the Medicaid state fee schedule for the amount of services provided and the individual provider's costs, and that would be filled out in the cost report of providing the allowable Medicaid services to Medicaid beneficiaries. Some states have elected to use the Medicare fee schedule and the amount that ambulance services are paid through Medicare, and they can pay up to the difference between the Medicaid fee schedule and the Medicare fee schedule, which tends to be higher in almost every state. Also, states may elect to use commercial payer rates. That's something we call average commercial rate, and that's a calculation that they need to justify. They usually use the top 3 or 5 commercial payers, and they average those rates, and they can pay up to that rate with a supplemental payment. And as the slide notes, CMS often raises a number of considerations to states regarding the payment methodology that they select for these supplemental payments. We're trying to ensure that payments for services and supplemental payments are allowable and they're economic and efficient according to Medicaid regulations. And that's the end of our presentation. So thank you. I'll turn it back to the host.
Thank you. Next up, we have Maria Durham, who will present on Medicare ambulance fee schedule.
Hi there. Thank you so much. I worry that I'm not going to be quite as quick as my Medicaid colleagues, but I'm going to try, but I'm really excited to be here today. And I see a lot of familiar faces, a lot of familiar names, and also folks that I don't know. And I just wanted to really quickly appreciate that everyone's taken time out of their busy day to listen to this segment. I think it's a really important segment, but I know your time is very valuable. And my understanding is there's time for Q&A at the end of this segment. We will definitely hang on so we can answer any questions. I've also brought my colleague, Amy Gruber, who is the lead for the ambulance work, and both of us welcome any questions. Next slide. Next slide. So today we're going to talk a little bit about an overview of the ambulance benefit, unpacking the fee schedule, talk a little bit about health equity, COVID-19 flexibilities, and then I think somebody asked in an earlier session about the ground ambulance data collection, and I'm going to talk a little bit about that. There's a much longer session tomorrow about that piece, as well as I included in the slide deck some references because we don't have a long time together. Next slide. Okay, so included in this slide is the authority that established the Medicare ambulance fee schedule. And the ambulance fee schedule was established through a negotiated rulemaking process. So it was created with a committee just like this one with input from the industry. And my team is responsible for the Medicare ambulance fee schedule. There are some other related ambulance things going on. The ET3 model, I think you're going to hear from those folks. You just heard from the Medicaid folks. There's some other things that aren't in our division, but much of the Medicare policy and payment is in our division. Next slide. So not sure how much of a background everyone in the public has about our ambulance work, but my mother told me never to assume. So in the next couple of slides, we're going to break down the Medicare ambulance fee schedule payment in detail. And I'm also going to give you a brief overview of the Medicare ambulance transport benefit. And first and foremost, it is a transport benefit that covers medically necessary ambulance transport services that meet the requirements identified on this slide. Just as a reference, medically necessary is defined in 42 CFR section 410.40. And this slide also lists the covered destinations for ambulance transport. And to note, this was temporarily expanded during the COVID-19 public health emergency. And I'm going to talk about that in a later slide as well. Next slide. So like many other Medicare Part B benefits, ambulance transports use the lower of the actual billed amount or the Medicare fee schedule payment methodology. And Medicare will pay for 80% of the approved amount with applicable deductibles and coinsurance. The coinsurance is 20% after you've met your deductible. And just to kind of give you a sense of what we spend, we spend about $5 billion a year. Which isn't as large as some of our largest benefits, but it's still, a fairly large chunk of change. And this benefit, it's particularly important because, as everyone here knows, this provides just key services for our bennies, transporting them when medically necessary to the nearest appropriate facility that can treat a patient. This is probably one of the most important benefits that we have. Next slide. Okay, so how do we pay and what makes up the Medicare ambulance fee schedule? And this is a super meaty slide and it describes just that. And I'm going to break it down in detail, but stay with me because there's a lot of pieces to it. First off, the ambulance fee schedule rates were established in 2002, the ambulance fee schedule final rule, and they've essentially worked the same way since their inception. There are three components to the payment, and I'm on the first bullet here. There's a base payment that is a nationally uniform dollar amount to calculate each HCPCS code payment amount. We use something called relative value units associated with each of the HCPCS codes to set a numeric value for ambulance services relative to the value of the base level ambulance service. So there are market differences, as all of you know, in resources necessary to furnish the various levels of ground ambulance services. And the highest RVU is, for example, our specialty care transports, because by definition, they're very resource intensive, and that would be reflected in that base payment. And of course, all of this is updated annually by the ambulance inflation factor. We're going to talk about that later as well. So you've got your base payment. Then you have a separate payment for mileage to the nearest appropriate facility. And third, there's something called a geographic adjustment factor. And the geographic adjustment factor, sometimes called the GAF, I'm going to try to stay out of acronym soup, but it's hard to do this. The GAF is the non-facility practice expense of the geographic practice cost index. Sometimes we call that the GPCI of the Medicare physician fee schedule. And this is the piece of the fee schedule that adjusts payment to account for regional differences. And it is applied to 50% of the air ambulance base rate and 70% of the ground ambulance base rate. So the ambulance fee schedule geographic adjustment factor is updated annually by the physician fee schedule practices expense geographic practice cost index, or the GPCI. So the base rate is multiplied by the geographic adjustment factors and added to the mileage rate to form the total fee schedule ambulance payments. But we're not done. So there are 2 permanent add-on payments and 3 temporary add-on payments. The 2 temporary add-on payments include 50% increase for the standard mileage rate for the ground ambulance transports that originate in rural areas where the travel distance is between 1 and 17 miles, and a 50% increase to both the base and mileage rate for rural air ambulance transports. The 3 temporary add-on payments, and just to note, those temporary add-on payments are effective through December 31st, 2024. Those are where you see for ground ambulance additional payments for rural and super rural. Geographic designations are based on zip code from the point of ambulance pickup. So super rural designation is based on the transports that originated in a rural area defined as the lowest 25th percentile of all rural populations arrayed by population density. So you'll see on this slide what those rates, temporary and add-on payment rates are. Next slide. Okay, last but not least, two other important items about the Medicare ambulance transport benefit that affect payment. Ambulance organizations must accept assignment. That means that Medicare allowed charge is payment in full, and the patient cannot be billed for additional unpaid costs beyond their copay and their deductible. Additionally, all base and mileage rates are updated annually with an inflation factor. The ambulance inflation factor is the CPI-U, June over June of the previous year, reduced by the multi-factor productivity. And the CPI-U is something we derive from the US Bureau of Labor and Statistics. And the MFP is something that we get from our Office of the Actuary. So to kind of put that all together, the MFP for 2023 was 0.4%. The CPI-U for 2023 was 9.1%. Therefore, the inflation factor for calendar year 2023 is 8.7%. Next slide. Okay, so as I'm sure you're all aware, equity is such a priority for our administration, and we put in place some temporary changes during the pandemic just to address the disproportionate and severe impact of COVID-19 on underserved populations. So in the next slide, I'm going to go very briefly over this, but we put these in place because rural communities are disproportionately affected and vulnerable to physical and economic impacts. It was interesting. I think it was ASPL that earlier on talked about speaking at the Rural Health FACA Committee, and I actually went to that meeting and spoke to them about it, and they really emphasized just how dependent rural communities were on ambulance services and how dependent those ambulance services were on volunteerism, for example, and how poor volunteerism was during the pandemic and has stayed relatively low. And I think that's definitely a challenge, that I wanted to surface. Next slide. So for the ambulance transport benefit for Medicare, we introduced two flexibilities to try to address the challenges of the pandemic by expanding the list of covered destinations for ground ambulance transports and paying for treatment in place. And a short description of these flexibilities are detailed on this slide. The expanded list of covered destinations speaks for itself. It was primarily meant for like pop-up tents, hospitals without walls, and other solutions that were necessary during the pandemic, and we wanted to be able to provide that flexibility. The treatment in place waiver allowed Medicare to pay ground ambulance providers and suppliers in cases where that individual that would have been would have met the Medicare criteria for medically necessary transports to the nearest facility, that would have treated his a patient's condition, but somehow that didn't, that wasn't able to happen because of a community-wide EMS protocol during the pandemic. And we provided some flexibilities for that as well. So on that slide, you'll see our COVID-19 FAQ link on Medicare fee-for-service billing. And one thing I would note is, as you all know, the end of the public health emergency is set to be 5/11. And that's when these flexibilities would end as well. Next slide. So last but not least, and this is definitely the good stuff, the ambulance fee schedule was established in 2002 and was fully implemented by 2006. And as I said, we still use this general method to pay for ambulance services. That is via a fee schedule that includes an annual ambulance inflation factor and geographic adjustment factors, and adjust payment to account for regional differences. We kind of pay that way and have for many, many years. But Congress heard the message, and I think the agencies have heard the message that that payment may not be enough, that payment may not be accurate. And one of the challenges is having very limited data on costs from providers. Most ambulance organizations are suppliers and not providers. So we have limited data with which to assess how else a payment could be made. So Congress kind of heard that call and enacted legislation, BBA of 2018, that requires CMS to collect cost, revenue, utilization, and other information on ground ambulance organizations and provide that information to MedPAC, who will submit a report to Congress on the adequacy of payments for ground ambulance services and the geographic variations that we talked about and the costs of furnishing those services. And at this point, although we had a bit of a delay with the public health emergency, we have fully developed a system to capture this data in a user-friendly fashion. We conducted several rounds of UAT that were very successful, and brought ambulance organizations in to test the system. And we've also engaged in quite a few webinars and contents. We rolled out a new website that has all the information you would possibly need to report your data. And it's really important that reporting happens. And it was successfully launched in January 1st of this year. Next slide. So this slide depicts the overall process of the data reporting effort. This is something, again, that is really, really important, that we need to have in order to really understand the real costs and utilization and revenues for ambulance organizations. It's a really important benefit. So we started out notifying our people that were sampled to report. We had everyone submit some very initial information. We tried to be as flexible as possible so organizations could use their own fiscal year or report on the calendar year. There was a year of data collection, and then reporting is 5 months after that collection period. And you'll see that in steps 3, step 4. We had folks register for the web-based system. Step 5, we are reporting, as I said. And later on in the year, at the end of the organization's data reporting periods, we will notify participants that don't have a sufficient response. But this has been a great effort, and it's really important that that information go forward so that Congress can understand what the real expenses, utilization, revenues are for ambulance organizations. Next slide. Okay, so I just included some references on this slide. In case, I know we don't have a long time for the meeting, feel free to read up on anything I've discussed. And as I said, we will be around to answer questions at the end of this segment. And I really appreciate the time everyone took to listen to this. Thank you very much.
Thank you, Maria. We will now hear from Adam Beck, who will provide an overview of health plan coverage of ground ambulance transportation.
Thank you, and good afternoon. Again, my name is Adam Beck, and I'm the Senior Vice President for Commercial Employer and Product Policy at AHIP, the National Trade Association for Health Insurance Providers and Many Integrated Healthcare Systems. During today's presentation, I'll be giving an overview of how health plans determine coverage for ground ambulance transportation, including both emergency and interfacility transportation. In separate sessions, we'll be giving an overview and discussing other topics related to health insurance coverage, such as reimbursement amounts, network arrangements, disclosure of charges, and of course, potential solutions to balance bills. Over the next few minutes, my slides will be limited to detailing generally the levels of coverage that many commercial health plans provide for ground ambulance services, the destinations that commercial health plans will pay for ambulance transportation, the requirements that are typically associated with a plan's obligation to pay, and an example of common plan contract terms and limitations and exclusions. I do want to note that these are examples that are common in the industry writ large, but I am not speaking on behalf of any particular plan or carrier. And as we've discussed many times today, just as if you've seen one ambulance or EMS company, you've seen one ambulance or EMS company, Similarly, the specifics of health plan terms and coverages are going to vary, perhaps substantially, depending on the plan type, the funding type, the state, the carrier itself offering the coverage. But hopefully this will offer a base level understanding that will help guide our later sessions and our later discussions, including several tomorrow, where we can then talk about reimbursement approaches and challenges. And in particular, the reason that we are all here for this committee to figure out how to ensure that patients are taken out of the middle and ensure that ambulance and EMS providers no longer send balance bills to patients while determining an approach for reasonable reimbursement that covers the cost of this critical healthcare service and allows EMS providers of all types to thrive and to continue to provide first-rate, first response healthcare. And so with that, if we can go to the next slide. I want to start in the first few slides, like I said, by laying some groundwork on the different levels of ground ambulance transportation that will typically be covered under the terms of a commercial health plan. One being basic life support, and then you see the acronyms in the parentheses there next to that are often referred to on your summary of benefits and coverage or in your plan contract terms. So BLS would include the provision of medically necessary supplies and services, as well as BLS ambulance transportation. And that's going to be defined by state law where the transportation is provided. So again, that's an area where what constitutes BLS may vary from Maryland, versus another state like Colorado, just as an example. Then there's advanced life support level 1, which is going to include the provision of medically necessary supplies and services and the provision of an ALS assessment or at least one ALS intervention. An ALS intervention is a procedure that must be performed by an emergency medical technician or an EMT paramedic in accordance with state and local laws. Next slide. And then coming after ALS 1 is, of course, ALS 2, Advanced Life Support Level 2, which includes the provision of medically necessary supplies and services, as well as the following criteria: at least 3 separate administrations of 1 or more medications by intravenous push or bolus by continuous infusion, or at least one of the procedures listed here on the screen, such as manual defibrillation or cardioversion, ET intubation, central venous line, cardiac pacing, chest decompression, surgical airway, or an iOS line. And reading through that list is a clear reminder that I'm the lawyer here speaking from this perspective and not one of the EMTs that were speaking to us this morning. So apologies for any mispronunciation of the different procedures. That gives you an idea of the ALS 2 level. If we can go to the third slide. Then there's specialty care transport, which is going to include the provision of medically necessary supplies and services at a level of service beyond the scope of an EMT paramedic. SCT is going to be a form of interfacility transportation of a critically ill or injured beneficiary that is necessary because that beneficiary, in other words, the patient's condition, requires ongoing care that must be furnished by 1 or more professionals in an appropriate specialty, such as an emergency or critical care nursing facility, freestanding ER, respiratory or cardiovascular care that's going to be necessary, or by any other paramedic with additional training. And then finally, there's a paramedic intercept that a plan would typically cover. And this refers to an entity that provides ALS services, but does not actually provide the ALS transport. So a paramedic intercept may be required when only a BLS level of service is provided and the beneficiary then requires ALS level of service, such as a chest decompression. So those are the levels of coverage to try and give us an idea of the universe of the different types of transportation and the different types of EMS services that a plan's contract terms would likely then provide to the patient beneficiary. If we can go to the next slide. Then there's the destinations, recognizing that we've got emergency transportation, we've got interfacility transportation that may involve transporting the beneficiary patient to or from one of these types of facilities. And that could be to a hospital, transportation to the beneficiary's home, which is generally not going to be covered unless you purchase a plan that does specifically cover transportation back home. Or the third could be to a physician's office. And that's generally going to be limited to situations where the transport is en route to a covered destination, where the ambulance stops because of a beneficiary's dire need for professional attention, and immediately after, then the ambulance would continue to the covered destination, which is typically going to be a hospital, a freestanding ER facility, or something like a critical care nursing facility. Next slide. Recognizing that that's going to be the universe of the types of transportation and the places where a plan is going to offer coverage, then this gets into a lot of the meat of the issue when we before we get to the reimbursement question that we're going to be talking about tomorrow. And that's going to be the really criteria that the plan is going to apply to determine whether or not this particular transportation is going to be covered under a plan. And again, this is a hypothetical example of general plan terms that we're going to see in commercial health plans, particularly those that are offered by an employer. In other words, employer-sponsored insurance or employer-provided coverage. And those are going to turn on 3 criteria. One, that the transportation is medically reasonable and necessary. So it's got to meet usually 2 criteria: that due to the beneficiary's condition, the use of any other method of transportation would be contraindicated, and that the purpose of the transportation is to obtain a covered service or to return from obtaining such a service. In other words, that the treatment itself would otherwise be covered under that beneficiary's plan. Second, the destination is local. As a general rule, the ground ambulance transportation destination must be local, which means that only mileage to the nearest appropriate facility equipped to treat the beneficiary is covered. And as I think we have alluded to several times today, and we'll get into throughout the sessions later today and tomorrow, a lot of the questions about what constitutes the nearest facility and what is a reasonable per mileage reimbursement rate to that nearest facility or the nearest appropriate facility is a key question in trying to establish a reasonable methodology for reimbursement for different types of ambulance transport. And lastly, the criteria that the facility is appropriate. So some circumstances that may justify ground transportation to a more distant institution could include a scenario where the beneficiary's condition requires a higher level of trauma care or other specialized service that is only available at the more distant hospital. A specialized service is a covered service that is not available perhaps at the local or most near facility, such as a hospital that might not be a level 1 trauma center or otherwise not equipped to provide the medical needs, to satisfy the medical needs of that particular patient at that particular time. Or it could be a scenario such as when no beds are available at the nearest institution, even if that institution otherwise would be equipped to provide the necessary level of care. Next slide. So I want to give a specific example that we could see in a standard commercial health plan with regards to coverage of emergency transportation services. And so you could see plan terms that allow for transportation to the nearest hospital that can provide services appropriate to the covered person's illness or injury, transportation to the nearest neonatal specialty care unit for newborn infants' treatment of illness, injuries, or congenital birth defects, or complications of premature birth that require that level of care. Ground ambulance transportation requiring BLS or advanced life support, as we talked about. Supplies that are needed for advanced life support or for basic life support to stabilize a member's medical condition. Should be another bullet after there that could include where we mentioned treatment at the scene, such as paramedic services on site or remote healthcare without the actual transportation, where the healthcare is provided by an EMS professional, but there is no transportation to another facility. The plan could cover wait time associated with that covered ambulance transportation. And the plan may cover transportation to a hospital that provides a required higher level of care that was not available at the original hospital. In other words, a rundown of many of the criteria that were laid out on the previous slides. Now, as we know, as with other medical services, there may be situations where some advanced determination, such as a pre-authorization or a prior authorization as a form of medical management, may be required. This is generally not possible, of course, in cases of emergency services for an emergency transportation. And so this is likely going to be in a non-emergency ambulance transportation, such as an interfacility transfer, where there is preparation time and there may be an opportunity to be able to determine whether or not an ambulance transportation company that is in network with that member or that beneficiary's company would be available to provide that interfacility transportation. There are also some common limitations and exclusions that plan terms may include, and that would include ambulance transportation where there's another mode of transportation that is deemed appropriate, or it's transportation to a home, residential, or other domicile or custody facility, again, unless the plan specifically provides for coverage such as to a beneficiary's home, or if ambulance transportation is deemed purely for members' convenience of transportation. That's going to be a common limitation or exclusion. Again, there are plans that are going to permit that type of coverage, but it's going to depend on the particular plan type that the member is enrolled in. So that gives us an idea, again, before we get to the reimbursement questions and how plans then actually determine payment amounts. And we can talk then about different network statuses and obviously how situations where, as is going to be the case in most ground ambulance transportation, as has been mentioned several times throughout the day, in most instances, because of the reality of you call 911 and the nearest ambulance that is able to arrive at the location to transport that patient to the facility is who's going to respond regardless of network status. And because of the flow of patients to a particular EMS or ground ambulance provider may not lend itself to the traditional health plan versus healthcare provider negotiations that allow for the supply and demand dynamic that allows for network agreements to foster in the same way that it could with, say, most healthcare professionals that operate outside the walls of a hospital. That gives rise to most ground ambulance transportation being out of network, and therefore the terms of a particular plan contract when it comes to reimbursement are going to very often turn on what type of coverage the plan provides for in-network versus out-of-network care. And a lot of that could depend on, for example, whether you are in an HMO type plan versus a PPO or POS plan, and what type of in-network versus out-of-network coverage is available under that plan type. Some of this is already impacted by state law, but it's in a very small number of states. If we can go to the next slide. That there are currently 10 states that provide some level of legal protections for consumers from ground ambulance balance billing. The states that are in green here on the slide, ranging from Colorado down to West Virginia here on the list. This, I think, is really kind of a preview of the meat of the discussion that we're going to get into tomorrow about balance billing solutions and why a need for national protections for consumers in every state, given that emergencies happen when you're not home, when you're traveling, and when network status may not be feasible, again, because of a lot of the different negotiation dynamics that are unique to ground ambulance and other emergency services that give rise to a need to remove that incentive that some, certainly not all, but that some EMS providers have to balance bill patients because of the need to make up revenue, obviously from perhaps lower reimbursement rates from Medicare or Medicaid, that by removing that ability to balance bill, that can change some of the financial incentives. And obviously, we're going to talk about different approaches, whether that's through the No Surprises Act, through congressional action, through regulatory reinterpretations or changes, as well as, I think, looking at the broader landscape of financial challenges that face, whether it's the public utility, the private, the volunteer, or the paid fire EMS providers of ground ambulance services, to ensure that everyone can remain financially viable, and that we're looking at the public payers as well, to make sure that the actual cost of ground transportation via an ambulance provider or EMS transport is accounted for in all of the different ways that nationally we pay for this type of care and this type of transportation. And so I think the fact that you can see the very small number of states that have attempted to tackle this for fully insured plans in their states, recognizing that it's about 110 million Americans who are covered by self-funded or self-insured health plans that are not able to be governed by state law. This really underscores the need for a national approach to ensure that no matter where a patient requires life-saving or critical emergency and ground ambulance transportation, that they will have not only the peace of mind that they're going to receive the highest standard of care, but that they are going to have financial peace of mind that they are not going to then receive a balance bill. So that covers my portion of today's presentation on the coverage terms and the methods of determining coverage by private or commercial payers. I think later in session 3, we've got some time, as we did in the prior to forum, for questions from both panelists and the public. So thank you.
Thank you, Adam. Next up, we have Asbel Montes, who will speak on coverage and payment requirements for health plans.
Hey, Adam, thank you very much. And Adam, you did a fantastic job. But I will just give some context. This part of the presentation was going to be done by an actual health insurance payer. But unfortunately, they were unable to join us at the last minute. So what we decided as a group was to just kind of maybe give some examples. And so what I decided to do, based upon a perspective of someone from the outside kind of looking in and giving some examples, and I won't be as eloquent as Adam has put in here and giving general broad coverages, but was kind of define what we see from a payer perspective on what the coverages are there. And I've really focused it based upon some of the charges within the No Surprises Act around emergency ambulance services and what that looks like. And then what would be available out there to be sourced from a broad perspective if you were an outsider just looking in. And so the next slide, and I won't belabor this point, but it kind of gets us going or whatever, and all the questions that you may have, I will allow Adam to answer them. But let's kind of talk just generally what Adam has talked about here about general coverage guidelines around emergencies. What we typically see and what we have seen in the data that's available, and I've given a lot of source documentation here from different respective carriers that are out there based upon publicly available information, is typically they will follow generally the prudent layperson's definition of an emergency. So for example, Blue Cross Blue Shield in the state of North Carolina actually defines emergency ambulance services at the prudent layperson's standard. And so what that means is the sudden or unexpected onset of condition of such severity that a prudent layperson who possesses average knowledge of health and medicine could reasonably expect the absence of immediate medical attention to result in a severe acute condition. Now, it's really important to understand the nuance of how the definition or how each payer or commercial payer may define emergency ambulance service. Generally, that happens. I'll also provide you with some examples as well, where sometimes the definition of an emergency ambulance service or an emergency service may be even more narrowly defined as well. So it's important to understand that as you work through. Number 2 is typically they generally cover emergency ambulance services that come through the equivalent of the 911 center. Now, Adam Beck opined already on the different types of levels and the different locality and different nearest appropriate facilities. So I'll belabor that point, but typically and generally speaking, if they fall within those certain coverage guidelines, medical necessity piece of it, following generally the prudent layperson's definition of an emergency, would have some type of coverage to the consumer or to the patient as well. Now, point is, and I think Adam said this so eloquently, as the ambulance or the ground ambulance industry has also indicated, is that when you've seen one insurance health plan, you've seen one insurance health plan, and they have many plan types as well. And so you could have an insurance plan, and then they have different plan types that might vary based upon the coverage. And I'll move to the next slide. So what I decided to do here on this next slide was kind of take and look and see if we take the 80-20 principle and the Pareto principle to say how many of all the covered lives from the commercial insurance area, what are the insurance carriers that make up these lives? And so what I decided to do is Forbes had a really good digest on this that they published out in the early of January of this year, relevant to, they actually listed the top 50. I condensed this down because we weren't going to go to the top 50, but if you want that information, the source is here as well. But the top 10, and this is based upon 2021 data, and it fluctuates based upon some of the preliminary 2022 data that's out there. But Kaiser Permanente would be your number one ranked with about 8.2 lives, if my eyes are reading here correctly, with Blue Cross Blue Shield of North Carolina being your top 10 with almost around 900,000 to 1 million lives covered. So what I decided to do here, and some of these individuals also are a combination. So when you're looking at lives, it's commercial. It could be Medicare Advantage members, could be also Medicaid population, because some of these health plans might have product lines associated with either Medicare or commercial. And so that kind of gives us a base to say how much is out there that is generally acknowledgeable from the consumer to really understand what is covered, what is not covered if I'm going to do some research. And so I did that for you. And so let's go to the next slide. And so I first looked and said, what is available to us if I'm a Kaiser Permanente covered live? And I'm actually looking at a specific plan type that is out there for coverage periods that begin on or after January the 1st of 2022. Where it was an individual plan type of an HMO. And so how is emergency medical transportation covered? So if I need immediate medical attention, according to the prudent layperson's definition standard, is there information out there that will tell me how is this covered? What would my out-of-pocket possibly be if I'm a participating provider or a non-participating provider? And we're going to get more into that subsequently with further presentations and even into tomorrow. And then of course, with solutions, as Adam kind of referenced and as we've been talking through this process. So for instance, for Kaiser, if I had emergency medical transportation, if I'm a planned provider, and I utilize an entity that is a planned provider, it would be about $300 a trip is what they're indicating that this plan type's out of pocket would be. And then if you're a non-planned provider, how much would I have to pay for that? About $300 a trip. And then if there are any limitations or exceptions to this particular plan, it's important to note that I keep saying plan type because you do have numerous different plan types that might be associated with one different payer. Go to the next slide. Now, the next one is United Healthcare Services. Most people have heard that. Generally speaking, a United Healthcare does cover emergency ambulance services as well. I'm not going to opine on non-emergency or anything else, and it kind of keep it specific to the emergency ambulance service provision, but they generally do pay for emergency ambulance services. However, information that was readily accessible to the public or to actually try to find, couldn't really find down to the different levels similar to what you saw with Kaiser in that different plan type. You might need to either be enrolled as a member or call someone to obtain more information relative to what out-of-pockets might potentially be if you access a participating provider or a non-par provider. And I know there are some subsequent that have some data around this that might be able to provide further a further window into what that might look like with some subsequent presentations that we have here as well. Now, as you can see in some of these, they give very specific examples on what would be covered as well. And this kind of goes to what Adam was talking about from his perspective and generally kind of walking you through what some of those nuances are. But plans might go through and give you actually examples of what that would look like. And United Healthcare does that. Let's move to the next slide. And this will be my last slide, and then we're going to kind of keep moving on. I know there's a lot of people that have a lot of questions, and we have a lot of questions to cover. So I don't want to belabor the point through the process. But here's another one. And so Elevance Healthcare, which owns several of these Blue Cross Blue Shield plans, Empower Blue Cross is one of them in the state of New York. And so this was available to you if you are what their commercial reimbursement policy might look like for EMS. Now, while there wasn't any associated understanding of out-of-pockets or balance bills, if you're a par, non-par, similar to what you saw with Kaiser Permanente and their plan type, this kind of lets you and alludes to what does the emergency ambulance transportation benefit look like? And this is where I indicated that generally they might follow the prudent layperson's definition of an emergency. This has a little bit of a different spin on what that definition would be. And so it'd be important to note that sometimes You might get a provider or a patient say, well, I thought this was an emergency, or I called 911, but it didn't get paid for, it got denied. Could be a nuance with how they defined what the urgent nature or the criticality of that transport would be. And it could be something similar to what you might see, generally speaking, here in the different of the nuanced policy related to emergency ambulance transportation. And so that concludes it for me. I'm going to turn that back over to you, Tara, and we will move on to the next presenter.
Thank you, Asbel. We will now transition to a pre-recorded session from Ritu Sahi on the anatomy of an EMS call.
All right, so sorry that I can't be with you right now in person to present this. I will be joining the group tomorrow, so if folks have questions, please, I will hopefully be able to answer some of them. The goal of what I wanted to talk about today is this idea that a reminder more than anything else that EMS is healthcare, and that what we do is not just sort of a transportation service or benefit, which I think is sometimes the challenge that we can have with EMS. And what I thought I would do is just go through the anatomy of an EMS call, kind of all of the things that happen both in the foreground, in the background, so that you, and also some of the support stuff that occurs, so that you can all see everything that kind of comes together to sort of make an EMS call, and specifically a critical EMS call where life and death matters. There is a video in this presentation, so that shows actual care on a patient. I'll just kind of put that up there as a warning, and there will be another warning before we get to that slide. So I think the best way to kind of look at this is, what happens in an EMS call. And when we think about kind of the EMS call, there's this whole timeline of events, and we'll go through each one relatively quickly. But the idea is that there are kind of things happening sometimes in parallel, other times in serial, which includes multiple agencies, and then also kind of feedback. So the first thing that happens, of course, is the emergency happens. And a big component of EMS is sort of identifying and teaching our patient population or our public that that this is what an emergency looks like. And that could be something like a stroke or a heart attack or severe hemorrhage. But somebody recognized that there is an emergency and they call 911. And that 911 call actually is where we like to say the patient's healthcare begins for kind of a couple of reasons. Typically in most systems, they receive, or the call is received by what's called a public safety answering point. In some systems, that point also does the dispatch, the management, and in other systems, they may identify the type of call and send the call to another dispatcher, or in many systems also the call taker is putting in data that is then electronically shipped to a dispatcher, who then does the dispatch and managing of the on-field or the field components. But the two main focuses of the 911 center are going to be to determine what is the most appropriate resource needed for the call, and how many of each resource. What is the level of those patient? The level of care needed. Is it what's called advanced life support or basic life support? And then how should they drive? Code 3, which is going to be lights and sirens, or code 1. And as an aside, one of the things that we are working on as an EMS community is reducing the amount of code 3 driving, because that's actually the greatest risk to the patient and the public. They then, so they determine what needs to go and when, but they also provide pre-arrival instructions. And in cases like cardiac arrest or choking or bleeding, those pre-arrival instructions that are provided by the 911 dispatcher or the public safety answering point operator are a life-saving component, whether it's to start CPR or perform a Heimlich maneuver or do things to halt bleeding, such as place a tourniquet or place pressure on the wound. Eventually, this 911 center dispatcher then deploys resources in my system that those resources could be both an ambulance and a fire engine or other fire resources. And then they arrive and provide on-scene patient care. And many of you remember Johnny and Roy, and this is why I still do this job. But you know, when we talk about what happens on scene, it is a mix of highly trained professionals along with technology, as well as kind of the background that goes into all of that. So you have your two paramedics here taking care of the injured patient, and the basis that supports them out all this are going to be, you see here, the drug box. So they have patient care supplies, but they also have the background of all of their patient treatment protocols, which started with their licensure. So they went to school, became paramedics, got licensed. And then in my system, we have to educate them on all of our protocols, which are separate from sort of policies and procedure. I just checked the length of our protocol book, and it is 335 pages in my system. So the amount and the complexity of care that is provided, it continues to increase on a daily basis. In addition, they have to marry technology to all this. And so these are two popular monitor companies. And so these devices monitor the patient vital signs, as well as generate things like a 12-lead EKG, which is to look for a heart attack. And then in those components all come together to provide care right on the scene, which is one of our goals, as well as transport the patient to the hospital with kind of ongoing care. But the next question really is also, where do we transport this patient? Do these patients need to go to an emergency department, just any emergency department? Should they go to the closest hospital? Should they go to the trauma center? Should they go to a cardiac center, ped center? We have stroke centers in my system. So again, these are all sort of clinical healthcare decisions that are made as part of the patient care. And so again, just to identify that this is not just an enterprise of transporting a patient to the hospital. So what I'd like to do, you know, the best way to kind of demonstrate all this is to just kind of show you a video. This is actual footage of a cardiac arrest call. This is a call that occurred in Portland. American Medical Response, who is the ambulance provider, along with Portland Fire, responded to this patient. This video was created by AMR as a celebration for EMS Week. The patient who you will see gave permission for this video to be created. This video is now widely publicly available. And so it is not any type of HIPAA violation or anything like that. And additionally, the patient did survive. The entire video is a nice interview with him. So in case anybody is sort of make sure that people are not triggered by that. So let's start this video.
My life has been fairly uneventful. I've been able to return to all of my previous activities and occupation, and I've had no residual effect from it, essentially.
So again, in looking at that video, you just see the entire components of the system that we talked about coming together. The idea that they called 911 and they were instructed to do compressions. The idea that the first responder was a fire agency arriving with equipment that is specialized for the care of these highly critical patients. That the crew themselves bring a wealth of knowledge and experience to manage these critical patients, and that our goal in EMS is to deliver the patient to the hospital in better condition than we found them. So again, we don't just transport them, we begin the clinical evaluation and treatment, and hopefully impact outcomes in a positive way. Other places are just critical pieces of information to think about 1 in 4 to 1 in 3 911 calls or ambulance dispatches result in a non-transport. And there are many different reasons. Some of that is that the patient just isn't there. Some of that the person ultimately refuses transport. But there are also other clinical situations where even in some systems might even be appropriate to see, evaluate, treat, and then actually non-transport the patient. Diabetic emergencies with a low blood sugar are one sort of common call like that. Overdoses that are reversed. I think in most systems, we would prefer those patients are transported, but ultimately some of those patients refuse. And then some cases of minor trauma. CMS is in partnership with various EMS agencies on looking at ways to reduce the likelihood of transport through triage mechanisms. This is called the EP3 program. Unfortunately, this program started in sort of early 2020, and I think that some momentum was lost due to other circumstances. In our system, we are strongly considering implementing a nurse triage model so that when somebody calls 911, if they measure out as a low acuity patient, rather than sending a resource, that we triage them to like an advice line where they can either get an appointment or those sorts of things. And then other things, activities that EMS provides that are again part of the healthcare continuum. They look at frequent utilizers of services and try to impact the social determinants of health that may cause them to be frequent utilizers. They work side by side with hospitals on high risk patients to reduce readmission, and then looking at other high risk populations. In my own system, we have a follow-up system where patients who have a opioid reversal event are then followed up by our community paramedic who then works with them to see if they are interested in developing a plan to get into treatment. So other kind of pieces of information or systems that are out there. So, in conclusion, just to kind of bring this around, EMS is not just a transportation system. It is clearly a component of healthcare. The healthcare begins as soon as the 911 is called with the public safety answering point. And this kind of care that we provide in the field requires significant infrastructure, which includes education, training, policy and protocol development, and then significant coordination of resources. I just want to have a couple of acknowledgements. Tim Case and Ben Sorensen, who work in our EMS system in Washington County, Oregon, actually created some of the initial slides on the anatomy of call, and then Mike Verkest, who was the creator of the cardiac arrest video. So thank you for your time, and I look forward to the work that we do as a committee.
Okay, I will now turn it back over to Asbel for committee and public feedback.
Perfect. And thank you for that as well. And I promise to make sure that I stay on time on Eastern time as well. So we've got a few minutes here, and I see that the hands are being raised to ask some questions. Just to note with Dr. Sani, I appreciate him sending in a pre-recorded to kind of talk us through specifically about the patient, because that's what it is, core and center of what we're focused on with this committee, is to ensure that we do no harm to the patient. And he'll be available for questions as we continue to keep working through the deliberation as well. So I'm going to first turn it over. Pete has his hand raised as a committee member, and I know I've been recording, and there's been several of us monitoring the chat queues to try to get to some of your questions relevant to this piece as well. But I'll first give it over to Pete, for your questions.
And thank you, Isabel. I've got some questions for Ms. Durham and for Mr. Beck. How do you want me to address those? Ask them all, or start
Why
with one?
don't you, let's first go with Ms. Durham.
Okay. All right. So my question there, and thank you for the presentation. It not sure it brought back the greatest memories, having sat on the negotiated rulemaking committee for the ambulance fee schedule. I just wanted to bring up some clarifications on it, and I'm going to cover a little bit tomorrow in it, but I just wanted to bring it up now. And that is that so the GPCI, for example, the GPCI increase, I just want to make sure everybody knows it's only applicable to 70% of the base rate. It does not apply to 100% of the base rate. So it could be that you're in New York City and the cost is X, but the GPCI only applies to 70% of the base rate.
And I know this is ground ambulance, but it's 50% of the air ambulance rate as well.
Yep.
Yeah.
The CPI increase, which, is the ambulance inflation factor, and everybody talks about, the ambulance inflation factor, and that's the way to identify increases in annual reimbursement. When the AIF was originally established as part of the, I think the BBA of 97 process was built in, and then we built it into the negotiated rulemaking process. It was based on CPI urban. The issue is, and it couldn't go negative, it had to be a positive, because the terminology that we used was increase. And so it was an increase, was always neutral or an increase. It never went negative. After the fee schedule was put in place and after the transition occurred, we were in the Great Recession. And so they turned around and Congress changed as part of the BBA. Congress went in and added the multi-factor productivity reduction. It was added against the direction and against the input from multiple CMS actuaries. From Richard Foster, the chief actuary at the time, John Shadow, M. Clint Clemens, all of the actuary folks at CMS said, you can't do this to suppliers. Because suppliers, the CPI is already built into the output price index. If I'm remembering all this correctly. And then we're going to reduce that by the multi-factor productivity. Essentially, we have to create twice the productivity to break even. And we are suppliers, and we've identified ambulance doesn't have the ability to scale back operations because we have response time requirements. We don't get the ability to say you can sit in our waiting room and it's okay to be there for 4 hours, because the contracts that are established state that we have to be there in a certain period of time, be it the paramedic coming on the engine of the ambulance and the ambulance itself. We have 90th percentile. So the AIF is artificially reduced against the direction of the CMS actuaries. And I've got the actual documentation for it if anybody needs it. But that ambulance inflation factor is no longer valid and has not been valid since 2000, the Balanced Budget Act of 2010. So.
Do you have a question, Pete, for Maria?
I just didn't know whether or not CMS, having all that information on the on that AIF, if I just want to make sure CIF or the CMS is putting that forward, that their own actuaries and everybody else do not feel that applies to ambulance and suppliers. And I just don't know if there's been any update from the CMS folks on that issue.
Yeah, I'll defer to Amy, but the challenge is the MFP is statutory. So.
Understood. I just want to make sure this committee realizes that the AIF should not be applied to commercial insurance because it is an inappropriate identifier for increases in cost of ambulance.
So what we'll do is, Pete, if you could provide that information to Shaheen and I, we'll make sure the committee gets a copy of what you're talking as they continue deliberations on the cost side of it. I don't know if Maria, if Amy's there and wants to make a comment, or it appears that that's more of a statutory requirement based upon what you're indicating.
It is a statutory requirement. I believe it's, oh gosh, somebody keep me honest here. I believe it's in 1834 I3.
Oh, that
1834
worries me that you
I3B.
remember that.
L, there we go. L.
You
This
got
is why Amy is here. She keeps me honest.
There you go. There you go. And
I
then
do
I
have some
think,
questions for Mr. Beck, if you want me to get into those, or do you want me to wait?
Pete, I'm fine with you. One more question, then I'm going to go to Sean.
Okay, so Mr. Beck, thank you for the presentation. And I know a lot of the issues, a couple of things are, a lot of the stuff that was presented is Medicare definitions, which really don't apply in the commercial industry, although a lot of times that's what people use. And so the other thing is that the insurance companies, they don't necessarily identify the in-network, out-of-network. They just say, here's what the component is. If it's $150, if it's in network, it's $200. How do the insurance companies come up with what they're determining to be the appropriate payment? When I get EOBs from insurance companies, the same insurance company says 125% of Medicare, 200% of Medicare, 300% of Medicare. And then you've got Kaiser, who pays the full amount almost all the time. We get between, in Oceanside, and I'll present this tomorrow, but in Oceanside, we get between, why is it that we're getting between 48% to 95% payment from insurance companies? Why is it that the insurance companies are able to make these decisions from Kaiser, who pays great, 91% or greater, to 48%? How is that appropriate within the insurance industry?
So, Peter, thank you for the question. I'm not sure that I'm entirely following what the question is. I'm definitely hearing the commentary on the fact that there are different insurance companies, and I think we addressed that with the idea that just as Oceanside is a different EMS or fire company than somewhere nearby, is your point that there are different standards because there are different companies? And when you say, I guess I'm not following when you say 91%. Are you referenced several times the Medicare rate? Are you referring back to the Medicare rate, or are you talking about 91% of the billed charge? Because I think if you're talking about billed charges, the question I would ask is why are the billed charges so substantially different without any rhyme or reason to whether it's the per mile rate or the base rate? Why is there such a variance? And is your point that billed charges should be paid in full?
Well, I think the issue is that I'll be explaining my bill charges tomorrow, but for example, my ambulance transport rate, my mileage rate is set according to our city code, and it's based on the actual cost to provide the ambulance transports in terms of outfitting, maintaining, fueling, everything, ambulances. So it's an actual cost. And so we've got Kaiser, who pays 91%. And I've got others that I won't mention who pay 48%. The insurance industry, why is it that Kaiser is chosen to pay and be the wonderful payer, and the other insurance companies have decided that they're going to pay sometimes 48%? How does an insurance company say 48% is an appropriate amount to pay of an ambulance transport, meaning that they're paying essentially Medicare rates? How is it that we've got that wide variety? Yes, I understand the rates are there, but the rates, I can just go from California and most places, the rates are established by government entities based on cost, but.
So your question, Pete, for Adam is why the varying of that? Can you answer that, Adam?
Yeah, so I mean, generally speaking, I mean, you raise Kaiser Permanente, which is a unique model. Kaiser is, of course, it's an integrated health system where their payment structure, because their business model is different than, say, a United Healthcare. So their payments, whether we were talking for ground ambulance transportation or for hospital services, they do have a different model. I think, I would need some more information about whether we're looking at an apples to apples comparison of what the 48% to the 91% is if they are of the same charge. But each company has different negotiation standards based on their particular business model and the consumers that they serve. So you are going to have different companies that would look at the allowed amount, the bill charge amount, and determine whether or not that is appropriate under their contract for reimbursing for that particular service. And I think what you raise is one of the issues that presents such a challenge, and what we really are here in large part to offer recommendations on as part of this committee is that you've got really a disintermediation of who the customer is because of the nature of the fact that you have, as you point out, cities or counties or other municipalities that are generally setting what the legal reimbursement rates are, that those counties are not necessarily then the customer or the negotiating partner of the insurance company. So the fact that a county sets a particular reimbursement rate would not itself drive the contractual obligation on a plan to reimburse at that particular bill charge. I think one of the things that I hope this committee takes seriously is the consumer side of this, to make sure that we are thinking about what the bill charge amount in relation to the appropriate allowed amount would mean for a consumer, rather than simply defaulting to bill charges, which is part of the reason that when you have high bill charges, you have the high rate of balance billing that burdens consumers with excess costs. So we really want to be focused, from my perspective, on a solution that ensures a reasonable reimbursement rate based on a predictable standard that covers the costs of transportation, but doesn't overly burden either the consumer directly or the consumer through their broader health plan.
And I think that's a really good point, Adam, that you bring up here is this, and just to remind our committee members and the public as well, this is the first of many meetings we will be having as we try to come to a solution to discuss, number one, Peter's question regarding the variability of reimbursement rates to ambulance providers, and then Adam's response to that, relevant to the different types of plan types and how that looks based upon models. So this is great dialogue. Sean, to get to your question, and we're getting a lot of questions coming from other committee members in the chat, so I'll try to get to these within our allotted time as well. So Sean?
Yes, excuse me. Thank you, Asbel. My question goes back to the first presentation on the state Medicaid programs, I believe Asher probably, with the GEMT supplemental payments to public, available only to publics. I'm thinking about in the state of Washington where I work, and I believe Rhonda that's on the committee also is probably familiar with this, where the Medicaid payment is like $115 to respond to a call, and the first 10 miles aren't covered with any mileage payment for a private provider. But with that GEMT supplemental cost payment, a public provider responding to the exact same incident could recover $1,000 or more dollars, a multiplier of 10 on that type of response for the same patient in the same place, just based on provider models. So is there data in aggregate from CMS on what these GEMT payments are? And then is there any sort of an audit process that goes out to, kind of look at, it mentioned, there was some slide that mentioned whether or not there may be some concerns about if they were directly attributable to the Medicaid benefit or not. And I was curious about both of those things.
Yeah, sure. Thank you for the question. I can certainly try to provide a little bit of information. Probably may not be what you're looking for, but I'm not sure if there is data, and I'm writing down the question as I speak, but I'm not sure what I shouldn't say I'm not sure if there is. I'm not sure what data is available on GEMT payments using that make cost-based reimbursement. We can certainly look to see if we can find that information out. First, yes or no, is that data available? And then two, to what level would that data be available? But we can certainly look and see to see if that information is available. I think that's the first question, is that available? And then what was your second question?
There was a slide where you mentioned CMS, I believe you had either issues around allowable costs, and I was curious if there was something that prompted that, if there was any particular category of costs that were submitted that weren't allowable, or any information around that.
Right. Yeah, no, I mean, I think the point about that is when looking at cost-based reimbursement, there are going to be, and I have to turn to Richard. Rich is really has much more experience than I do with cost reimbursement. But there will be costs that a provider will incur that are not attributable to providing a Medicaid service. It may be, and it may be that it is that the provider incurs costs for services, but those services are not Medicaid services, for instance, not something that's covered by Medicaid service. To me, a very easy example, which doesn't fit in with GEMT, of course, but is room and board. So room and board would not be an allowable cost under certain benefits. And so while a provider may actually incur costs for room and board for other patients, under the Medicaid benefit where room and board is not allowed, that kind of cost wouldn't be allowed in the cost report. So I know that's a very generic answer. And Richard, do you have any specifics that might help to answer that question?
Sure. First of all, you're right, Sean. The disparities, where a lot of states will target public providers, it's true. They could be paying thousands of dollars for a transport, and the fee schedule for privates is only 115 or something, like you said, on the fee schedule, whatever it might be for that state. I think that's something that a state should pick up on because they're subsidizing, to the detriment of the privates, they're subsidizing the publics, right, greatly, and they're probably driving them out of business. That is an issue. Secondly, I would say the biggest example of GEMT providers trying to stick extra costs into that are inappropriate for Medicaid would be the fire and rescue, right? If a fire truck goes along with an ambulance and let's say it's mandated by state law, that does not mean that it's part of the transportation, the benefit, which is covered under Medicaid. And a lot of times they'll try to stick those costs into the cost report, and that's where we have to push back. That's the best concrete example I have.
Thanks for that. Did that cover your questions, Sean, on that?
Yes, thank you. And look forward to being able to see what data we're able to view as we go through the process down the road.
And thanks for that information, Richard. Ted, I see your hand is raised.
Yeah, and Asbel, I appreciate how you were putting the context in about the different payers and the models, and Adam, how you were walking through that. Is there any aggregated data nationally at all, or how you group any of the payers as far as a percentage on which payers paid maybe full coverage or more work like Kaiser, and others that are at the 40% level, and in any type of version for us to look at? And then maybe even from that, is there analysis on how many requirements are put in there, like one ambulance transport a year, or any limitations around it? Is there any aggregated data that you've got you could share?
I don't know if I can, this is Lauren Adler, sorry, just to not by, I don't think there is anything. I mean, just to be blunt, I don't think any payer sort of released that. I'll be presenting in an hour or so a little bit on at least across United, Aetna, and Humana. The data doesn't let me identify who's who in there, but at least sort of looking at those three large commercial payers, looking at how often, full ambulance charges are allowed in full at least. And it's, almost 70% of out-of-network ambulances, full charge gets allowed in full, but I can't differentiate that by payer in my DUA. Sorry, DD.
Yeah, and I appreciate that. I think it's just, as you hear the complexity of, you have different payers in the same potential jurisdiction that have a rate schedule or whatever is set there locally. You have multiple different payers providing different amounts, and then even within that same payer providing different amounts, and which makes it difficult when you look at the single jurisdiction, or if you're looking at the neighbors and how you might have such a difference in wide variety, even the similar service types, and just trying to understand how that kind of concept is built on how the payers then create that type of rate table almost, which they're building, which makes it very difficult for the providers, obviously, to how to manage the infrastructure and that readiness fee, which is so critical. It's not just the transport, it's being ready to serve the calls we saw on some of those other presentations. So that's just what we're looking for. Appreciate it.
Thanks, Ted. And then just to follow up to you, Lauren, I'm assuming you've got information. We're going to hear about that in a subsequent presentation that you have based upon some data from some of the three larger payers. But to the point to Adam, from AHIP's perspective, have you guys done any analysis at all on that to answer Ted's question by chance, or are you going to have to go back and research and get back to us?
So I know that we don't have data from, as Lauren pointed out, that's not something that the companies themselves are going to report out. This is something, I know there was a question in the chat about whether the transparency and coverage rule would impact public disclosures. So I would need to see if these claim codes are part of the 500 services that are the initial list that is publicly disclosed. I would suspect yes, which is, there's going to be a wealth of public data that is now available under the transparency and coverage rule. So between that and some of the more private sources like Meritive Market Scan and HCCI data, we would be able to, do some data analysis that contrasts allowed amounts for different, we wouldn't see it per the actual payer. We wouldn't be able to say this is what Elevance pays versus what United pays. But some of that data would be available either through the transparency and coverage files, in all likelihood, private database data. But that's not something that at the trade association that we compile.
Okay.
That would be at the individual company level.
Okay. Excellent. Thanks for context. I know we've got a lot of questions here. I'm going to go to you, Sean, and then I'm going to take a few questions from the public as well. Go ahead.
Thank you. This one is for Maria Durham on Medicare. And again, it's probably about whether or not data is available, but thinking about the sort of disparities in reimbursement and payment across the very complex and multiple types of payer groups out there within Medicare, is there any data about the shift as Medicare Advantage has become a bigger and bigger player, and there's a significant cost share that is associated with a number of the Medicare Advantage plans that's growing, not shrinking, and where a provider of ambulance services or supplier of ambulance services maybe gets 80% of an allowable amount from traditional Medicare under Medicare Advantage, they may only recover 30% or 40% from the Advantage plan, and the rest gets shifted to the patient. And I'm curious if CMS is gathering data or has data available about those trends.
Yeah, so definitely a lot of conversations about the shift and looking at its effect on both Medicare fee-for-service as well as managed care. I will have to check back with our data area to see if they've done any specific studies that have been published that we can share, but I will for sure check back.
Great, thank you.
And while we've got you here, Maria, don't turn your microphone on. I did have a question here that, because you made it very clear in your presentation, and I think you reiterated it again, that Medicare is a transport benefit. And I think that's important for the committee to understand as well as the public to understand, which might differ a little bit than Adam's presentation from the insurance carriers. It appears based upon the general overviews, they might be more than just a transport benefit. And I know with Alexis and the CMI team being here as well, they alluded to the ET3 models like demonstrating outside that construct as well, possibly, even though it still could be seen as a transport benefit. Let me ask you this, the beneficiaries that might access the 911 system, so the Medicare Benny that accesses the 911 system, that where a transport benefit may not occur, so it's non-covered at that point in time. What are the requirements to balance bill a Medicare beneficiary in the event a transport benefit does not occur or that does not trigger? What are the requirements of the Medicare ambulance provider if they do that? Of course, I know the construct or some of the answers to that, but I want to kind of understand from that perspective how they get billed or whatever, and what the nuances are available there, if you can provide context.
Yeah. Amy, do you want to start?
Did you want to, or?
No, go ahead. I will not.
For Medicare Part B, to cover, it has to be a medically necessary ground ambulance transportation.
Right. So, you know, the balance billing applies, correct me if I'm wrong, Amy, to the Medicare, you know, the Medicare services.
So the Medicare beneficiary, if it's not occurring in transport, would potentially get some type of balance bill from the ambulance provider, technically, in that case.
Yeah, Amy, I'm not that familiar with balance billing.
I just know that with our ambulance fee schedule, there's mandatory assignment, where the ambulance providers and suppliers must accept the Medicare allowed charges as payment in full.
Yeah.
All right.
We can definitely, again, Asbel, I don't want to leave you hanging. We will look into it and get you a written response for the committee.
Perfect. And I think that would be important, Marie, like in instances they don't have to balance bill, things like that might be interesting for the committee to understand. Any questions here? I knew I have a question from the audience that I want to bring up, not seeing anybody's hand. I'm going to ask that. The one talked about, is there a minimum requirement or a federal or state requirement establishing a basic level coverage for ambulance services from insurance carriers? I'm not sure if this is around, is it an essential health benefit or something like that, but I'm going to turf that to you, Adam, if there is a minimum or anything that you know at that level. And then I'm also going to segue into, is it considered an essential health benefit or something like that? And then I might ask somebody from CMS or Society, or maybe Raj can provide some further context around that as well.
Yes, so ambulatory transportation is an essential health benefit under the Affordable Care Act. So we're going to talk about this a little bit tomorrow in one of the sessions about consumer disclosures and essential health benefits. So just, you know, at a high level, keep in mind that that applies to individual market plans and small group fully insured health plans under the Affordable Care Act. There is an impact for large group and self-funded plans in the sense that that would affect a prohibition on annual or lifetime dollar limits, which cannot be applied once a plan covers one of the essential health benefits. So the short answer is, in some plans, yes, there is a requirement because they are subject to the requirement that you cover all of the items and services that fall within the 10 categories of essential health benefits. But the vast majority of commercial plans are going to be either self-funded or large group plans, and the ACA does not extend essential health benefit requirements to them. That is in large part because even prior to the Affordable Care Act, essential health benefits without that name, but the benefits themselves were generally covered by employer-sponsored coverage, and that continues to this day. So you didn't really have a governmental need to set a a minimum requirement. And the other thing that I would point out is that that's not unique to ground ambulance or any sort of ambulatory transport. We actually really don't have much by way of mandates, coverage mandates outside of the ACA requirements for individual and small group plans. That's not how health insurance is structured in this country by and large, to have minimum coverage mandates. It's really more the market that drives, at least on the employer side, drives them to provide this kind of the robust nature of coverage that would include things like ambulatory transport. But it's not a government mandate, no.
Hopefully that answered the question from the public comment on that. Thanks for that, Adam, and we'll look forward to the presentation diving more in depth on that tomorrow as well. As member committee, if you've got any more questions as we go through here, it looks like some of the questions have been answered within the comments as well that we've kind of begun to allude to. I know we've got a few more minutes here, I believe, from my team. If the committee still has questions for Adam or Maria and her team and some of our Medicaid folks as well. I'll give you a second here. The only other question that I had, and Maria, this might be for you, that I had put here that I had wanted to ask, and this was around your rural health component of the presentation. Has CMS identified, and you may not have to be wonderful to get the information back, but has CMS identified any access issues within the rural EMS space tied to the current coverages that have been codified into statute around the ground ambulance payment system? Or are you guys looking at that? Maybe the CMMI folks, they probably have left already. I don't know if there's some discussion around that.
Yeah, I think that is one of the things that we also want to interpret when we get the data from ambulance organizations. I mean, kind of overarching all of this, I think we have very limited data, particularly from suppliers, 85% of which of ambulance organizations are suppliers. And I think that's something we hope to assess when we get the data coming in. And we really kind of emphasize the outreach with rural, particularly tiny rural, volunteer nonprofits to really make sure that we're really covering their real costs as well. And even if they don't bill a large volume, which, as I think somebody pointed out in one of their previous presentations, very few ambulance organizations have huge volumes of billing, but their costs are still really important too to consider. So I think that's something we're hoping to get as the data collection proceeds.
Okay, seeing any other questions, kind of paying attention to the chat, a lot going on in the chat, of good dialogue here as well. Any other questions? I'm looking to see if I've got all my questions answered so far. Oh, I did have one question, and this might be Adam or Lauren. I know this might be covered in your presentation as well, but I did write as you guys were going through, or Adam, as you were going through your presentation regarding some of the levels, is around emergency services that might be denied due to no medical necessity or medical necessity related down to the level of those level of service codes that you outlined. Do you guys have any data around like the percentage of that on AHIP side of it? Or Lauren, I'm going to turf that to you to see, with you being the data analyst that you are, if there's any information around that.
Yeah, I can certainly take that question back and see if we have any data. I don't know. We've done surveys on prior authorization. I don't know if we've broken it out, by claim code or even by kind of category about ground ambulance. It is a situation where certainly there are claims that are subject to prior authorization. In the grand scheme of the total claims numbers, I know it's a very small percentage. But in fairness, I mean, I don't want to indicate that means it's an insignificant number, given the millions of claims that are processed each year. So it could be a very, very small percentage. We're talking 1 to 3% is the general rule of thumb of the number of claims that are subject to prior authorization. But that certainly then could mean, folks can chime in and say, they've got personal experience where, a particular claim, whether it was an interfacility, transfer or a non-ground ambulance claim was subject to prior authorization. But I know it's a relatively small percentage. These are difficult claims to really apply medical necessity reviews, given the fact that they are, in most circumstances, going to be emergency services.
I don't have anything to add. I've never seen any good data on the question.
Okay. Any other, Patricia, I see your hands raised.
Yeah, I'll just follow up on that. I think I don't know if it's clear, but based on whose determination is the medical necessity, right? So as the patient who's getting that interfacility transfer is hearing, we really think you need to get to the other hospital for this care. I think we have to think about that. I really encourage our committee to look at both of these. I think somebody earlier said it's a bad name for the non-emergency transfer, because usually when it's being offered, it feels like an emergency, certainly to the patient if you're being offered an ambulance. So I want to make sure that we kind of include that in there. And I don't know, Adam, do you know, like, how do plans look at that? Are they, I guess it kind of varies by entity, but if you brought in your physician saying, hey, I thought the ambulance was needed, does that play anything, or are you really looking at the individual's decision and their panic level?
No, it would certainly involve a clinician, and usually, as with other pre-authorizations, something like a peer-to-peer consultation, where a clinician that's employed by the health plan or contracted by the health plan is going to conduct a review based on whatever the set criteria for, say, that interfacility transfer is, based on information that's going to be supplied by either the attending physician or a clinician that is otherwise treating the patient beneficiary. But I think you bring up a really good point that, if we're, once we get to the point of trying to come up with solutions to make sure that, whatever the methodology or the approach that, different approach is, plural, that we might recommend for resolving out-of-network bills. I think we've seen from how the No Surprises Act has been implemented thus far that really having as much clarity in this, if we're talking in the statute or in a regulation in the regulatory text about what the actual criteria would be for, say, distinguishing an emergency transportation from a covered interfacility transportation. We really need to make sure that it lays out what the considerations are and who the onus is on for making the determinations. It's very easy, as you point out, to look at what may be an interfacility transportation, and it can very much look and seem and feel like an emergency. So that definition and the clarity around it is going to be really important.
To segue off of what Patricia just brought up as well, Adam, do you know if the health plans currently look at relative to if the call comes in via 911, and then as Patricia indicated from the consumer's perspective, if they're in a hospital needing a transfer, that could look and feel like it's an emergency as well to them. Do they look at that in two different categories around medical necessity? I've been following some of the chat and some of the comments in the chat where people start talking about to the nearest appropriate facility. What is the definition of that? And I do have a question for you, Maria, related to that, because there is some stuff in the comments wanting to know how that's defined by Medicare. But I want to really segue that because you guys follow some of the same similar principles or coverage principles that Medicare has that you covered in your presentation. So do you have any context around that?
Yes, certainly. I think kind of who is requesting through, through what medium, and I think in what timeliness you're requesting different types of transportation is going to be a factor in trying to determine whether or not it constitutes an emergency service. And a lot of this, I think, gets into the appropriateness of, say, the prudent layperson standard and the state definitions that are going to apply, depending on what the state law states as their definition of emergency service. in many states default to the prudent layperson standard, which is very subjective. And so I think, again, that kind of gets back to the need for having clarity, because I think as much as we can avoid kind of relying on, the eventual case law that would develop around a lot of this, that would be really helpful to make sure that, say, the recommendations are clear that if a call, for lack of a better term, is coming from 911 versus from a hospital that is already treating a patient, that is a consideration that we're very clear on how that's supposed to be evaluated in determining whether or not this particular transportation would be covered under whatever system we end up recommending.
And any questions from the committee? And Maria, we did have several questions there, and I don't mean to turf to you, but I'd like to.
And before you turf to another question, in 42 CFR 414.605, don't ask me why, I really do have that memorized. That's our definition section. We define an emergency response as responding immediately at the BLS or ALS 1 level of service to a 911 call or the equivalent.
So CMS has clearly defined it as an immediate response. And Adam, from your perspective, from the insurance side, they're still using prudent layperson's definition, which in your words is subjective and might be something that we need to consider as a committee based upon maybe the bifurcation, if it's a 911 or a hospital or something, looking for solutions.
I generally agree with that assessment. Yeah, that I think, weighing a consideration of how appropriate the prudent layperson standard is and what we're defining as that standard is going to be an important role for this committee.
Okay. Any other questions before I know Ed has his hand up, but I want to make sure that I get the questions here from the committee first. Okay, Ed.
Thanks, Asbel, and Adam, thanks for your part of the presentation. It was very helpful. In the interest of clarification, I think one of the things you've seen in the chatter pretty much all afternoon is there still seems to be a lot of confusion around the applicability of the federal No Surprises Act to ground ambulance. Do you think it would be reasonable for AHIP to put out a communication to its members that indicates that it is not applicable to the ground ambulance industry right now, which I think the CMS folks, the tri-agency folks, have made very clear today?
Yeah, so I think clarification on what regulations apply to what circumstances is the role of the regulator. So I would defer to CMS on any clarification there. I know there are instances where some plans in certain states have looked at their state definition of emergency services and interpreted certain ambulance-based transportation, such as interfacility transfers, as emergency services. And so I think, clearly in some instances, it's an open question. And it's really not for us as a trade association. I mean, we don't set regulations. So I think clarity on what the meaning of a definition under a regulation is and how that applies, I would really defer to my friends at CMS for the best approach to ensure that their regulations and the Tri-Department's regulations are being followed as they're intended.
We'll take that feedback back. Appreciate it.
Thanks, Maria. Any other questions from the comment? I know we have about 5 minutes here. Any questions from the committee for our presenters while they're here with us? I'm sure. Thank you, Maria and team. And Adam, because I'm sure we will be requesting more from you guys in the future. We so appreciate your feedback. Any questions before I turn this back over to Tara? Tara?
Okay, thank you. We will now go on break and we'll resume session 3 at 4 p.m. Eastern Time. Welcome back. We will now begin session 3 with Ed Marasco presenting on level of care.
Thanks very much. Appreciate the opportunity to be here, and certainly consider it a privilege to participate in this very important process that you are all undertaking over the next few months. Next slide, please. Essentially, I just wanted to share a broad background in healthcare, beginning with being a provider in the field and now working on several health system boards and working in the revenue cycle management space. Next slide, please. I was basically charged with several objectives. One is to explain the key aspects of the history of air ambulance payment system or the ambulance payment system as it relates to level of service. Also provide some list of the level of service and some descriptions, as well as identifying some of the key current challenges presented by the system that we have today. Next slide, please. So, in terms of the history and some of the things that have been talked about already earlier today, it is really right now considered still only a transport benefit. And there are some exceptions to that. And of course, Maria and others have gone beyond what I could certainly do in terms of describing those limitations and things of that nature. But it is a little bit, it does seem a little bit of a dichotomy, because we're talking about the levels of service and levels of care. And really, those aren't the core of what we have in terms of the way the coverage is written and designed to be handled. Next slide, please. So some of the key elements of payment, and we've talked about some of these earlier today. Obviously, medical necessity is a primary prerequisite to obtaining ambulance payment. The premise and application of those related principles can be problematic for suppliers and payers alike. And we've alluded to some of that. Some of the challenges have already been addressed today. One of the key aspects too that was talked about earlier, and again is very important, is that essentially right now we get, for ambulance payment, we get paid in two ways. We get a base rate reimbursement and we get a loaded mile rate. And if you go deep into the history of ambulance reimbursement and payment paradigms, you can see that essentially the base rate was supposed to approximate the fixed cost of providing services, things like having the ambulance as the base, the insurance, things of that nature. And the loaded mile rate was designed to cover variable costs, things like wear and tear in the ambulances, medical supplies used, and things of that nature. We've certainly evolved well beyond that. And the level of care is recognized, and reimbursement is used via the base rate to compensate for different levels of care that are provided. And there typically is no variable reimbursement on the mileage side. In other words, we typically get paid one flat rate. There's not different rates for different levels of care, which is ironic as well, because part of that variable reimbursement, you think about medical supplies and medications and things that are used. And as we talk about these levels of care, it becomes pretty obvious that the variable cost on an SCT call or an ALS2 call is very different than a BLS non-emergency call. Next slide, please. So when we talk about levels of care and service, there are essentially two distinct lenses through which to view level of care. They are essentially the clinical view of these levels of care and service and the payment lens of that care, or the payment algorithm, which has been used over time. So let's drill down on each of these. Next slide, please. So on the clinical On the clinical side, as you can see, we start at the lowest and most basic level at the first responder level, and it goes up through specialty care transport. And levels of care is primarily defined by the scope of practice of the clinical personnel caring for the folks who are sick. And the scope of practice is broadly defined based on those professional certification levels that are described here. And I think others have alluded to these as well. So basic life support being primarily an EMT basic, advanced life support representing everything from EMTs advanced through the paramedic level, and then the specialty care transport level, which is essentially defined as a provider beyond the level of a traditional ALS provider. So it could be a critical care paramedic, a nurse, a physician, so on and so forth. One of the major challenges to applying these standards is that the scope of practice can vary widely from jurisdiction to jurisdiction. In many cases, individual states may recognize different levels of certification and licensure than others. In addition, some scope of practice standards may vary even across jurisdictions within states. So you can see it creates a little bit of a challenge, and this nuance really makes proper coding and billing of ambulance claims, because the certifications change so much, a very difficult to apply paradigm. Next slide, please. So the payment paradigm is based on definitions that have been defined in payment policy over the years. Again, as has already been explained, the Balanced Budget Act of 1997 is what caused the formation of a national Medicare fee schedule for ambulance reimbursement. And this sort of was a landmark moment for ambulance payment policy because it convened that negotiated rulemaking process, which took 2+ years. And myself, Pete lost 2 years of his life on this one, and I was involved personally as well. And that 2+ years resulted in a new Medicare standard that has subsequently been adopted across much of the ambulance payment landscape, and not necessarily statutorily, but many of the other health plans, other payment third-party payers have adopted some of the same standards. So as we explore these levels in more detail, keep in mind that as you move up from the lower level acuity, that patient acuity, clinical risk, and costs increase as one moves up through the continuum from BLS up to specialty care transport. So let's dive in a little bit deeper. Can we have the next slide, please? So at the most basic level is the provision of BLS services or basic life support services. A basic life support service is essentially derived by evaluating the vehicle itself. So and it tends to be licensure of the vehicle based on equipment and capability. The crew composition, so in this case, EMT basics. The clinical needs of the patient at the time of arrival, and then ultimately the clinical needs of the patient during transport. It's also important to note, and we'll see this on the ALS level as well, that the payment paradigm allows for different reimbursement depending on whether or not the situation was an emergency or not an emergency. And we'll touch on some of that as we get into some of the challenges. Next slide, please. So at the next level is the provision of ALS services, and an ALS 1 service is derived by, again, the vehicle capability, which is how it's licensed, the equipment and capability that it has, the crew composition, and sometimes this can be advanced stages of EMT as well as paramedics, and of course the needs of the patient at the time the crew arrives as well as during transport. Lastly, the payment paradigm allows for a different level of reimbursement, once again, whether or not it's an emergency or a non-emergency situation. One important historical note here is that the genesis of ALS 1 versus the ALS 2 levels of care, which we'll cover in the next slide, really came from that negotiated rulemaking process. And as that process was underway, several members of the committee suggested that that ALS level payment should be rendered for all ALS operating agencies. And the constituents at the time cited readiness costs, staff costs, and in some cases, ALS mandates that existed in their jurisdictions for some of the agencies. CMS, which was HCFA back then, responded to that particular request, and that concept, for those of you who are Pirates of the Caribbean fans, the response was that they were disinclined to acquiesce to that request. And so essentially what CMS said was, we're not going to open up that can of worms, but we do acknowledge a couple of things. We acknowledge that there are indeed real costs, readiness costs associated with operating an ALS system, whether it was mandated or just a part of the regional system design. And so hence the compromise to split the ALS level of reimbursement into two levels was promulgated. And so the ALS 1 level was designed to compensate agencies when they responded to an ALS level chief complaint on an emergency basis. And there was an ALS assessment completed, but the patient was either transported ultimately with BLS or a lower level ALS care. CMS agreed, and the negotiated rulemaking ultimately codified this, that would constitute an ALS 1 level of reimbursement. And of course, ALS 2 is designed to compensate agencies for true advanced ALS level of care that was given throughout the patient encounter. Next slide, please. So essentially, and Adam did a great job, even though he's a lawyer and not a clinician, did a great job of describing this in his part of the presentation during the last session. Essentially, the difference between ALS and ALS 2 is the numbers of very specific interventions. So it's not all ALS interventions, everything that you and I would consider a skill set that's reserved for ALS providers, so intermediate EMTs or higher. But there were some very specific interventions, things like endotracheal intubation and certain kinds of medication and so forth, that really count towards qualification as ALS level 2. So essentially, when people have asked me this over the years, what's the difference? You know, an ALS 1 call is someone who has a complaint that warrants an ALS level of response, but ultimately the patient could be stable, and whatever that initial complaint was doesn't result in the need to provide lots of care. The ALS 2 level of care really is, you know, the typical empty the drug box kind of scenario, much like in Dr. Sawhney's presentation, what you saw in the video that was portrayed there. Next slide, please. So the next level up the food chain is specialty care transport, SCT level services. And essentially, an SCT level of services derived by evaluating, again, the vehicle capability and equipment. So in many cases, at the SCT level, there's much additional specialized equipment beyond what you would normally see on an ALS ambulance. The crew composition is certainly different. And again, the burden of proof is on the providers, on the agencies, but essentially, if a crew member is on the call, who's operating beyond the scope of a typical ALS provider, that particular transport may qualify for SCT. And again, this is very jurisdictionally specific. Scopes of practice change quite a bit, as I mentioned, from area to area. And so the easy part of this, the more slam dunk aspect of this can be, you know, when you have specialty teams like neonatal teams on board the ambulance, where you have a neonatologist and a neonatal nurse on board, in addition to the ALS crew member who might be there, it becomes a lot easier to make these definitions. Where it's gotten a lot more muddy over the years is when you have things like critical care paramedics and those individual scopes of practice. And does that meet the burden of the definition of specialty care transport? And again, as was pointed out earlier, these tend to be not 911 calls. These tend to be high-level interfacility transports, taking someone from an ICU to another, or maybe from an emergency department in a more rural setting to an ICU level of care. Next slide, please. So one of the other things that I was asked to consider was, you know, what are some of the areas of challenge? And so here are some of those areas that have presented problems from a reimbursement perspective, from a payment perspective over the years as it relates to level of service. Next slide, please. So one of the key things that is considered both in the BLS, the move from BLS to ALS, but also in that move from ALS level 1, level 2 is what type of call was it at the time the call came in? So essentially, was it an emergency call? And so the technical definition, and again, we've covered some of this earlier today, is an emergency exists when the call originates from a designated 911 center or the call originates from a 911 center equivalent. So there's still, for example, in many cases, there are still agencies that have 7-digit emergency numbers that ring to a communicator who may handle specific calls, not necessarily part of a PSAP or public safety answering point, but they may get direct calls for emergencies from healthcare institutions, nursing homes, things of that nature. And then the third element of this is when the agency responds promptly upon receipt of that request. So in other words, it's not a scheduled trip. It's not an urgent trip where we say, you know, when the next crew frees up, we're going to send them out. It is the call comes in and the response happens immediately. Some of the payers, and this is one of the challenges with this as well, and again, Dr. Sawhney in his presentation alluded to this, some payers have applied sort of the use of lights and sirens as a proxy for immediate response over the course of time, those code 3 calls that Dr. Sawhney described. And as you heard, and there's been a lot of research in recent years, and we've matured as a profession in understanding that the use of the lights and siren actually does present higher risk to the patients, to the public, and to our healthcare providers out there. So many agencies have scaled back the use of lights and sirens on emergency calls. And so sometimes this has confounded that payment policy as we work through the definitional aspect of emergency versus non. And so one of the things the committee may need to take up is and I think it was discussed in the last session near the end, is really maybe clarifying that definition and expanding on it a bit to make it more clear what constitutes an emergency versus non from a payment policy perspective. Next slide, please. So the other thing that really creates a problem from time to time on reimbursement policy, and that's the difference between ALS and BLS1, I'm sorry, ALS1 and BLS. And this tends to be a written distinction when it comes to that ALS assessment that's done, which is a key element of making the jump between BLS and ALS1. And that becomes a real documentation challenge. You know, there's quite a bit of difference in paradigms that are used to document emergency medical services calls around the country. People who are trained in different eras, in different agencies and different training centers may use different documentation formats. There's not one widely accepted standard around the industry. So you see some variability in documentation. And unfortunately, the definition of an ALS assessment has not really been codified in policy anywhere to make it very clear what those elements are. And so in a lot of ways, what constitutes a documentation of a proper ALS assessment can be very situational based on the chief complaint, based on the style of writing and documentation. So we do see lots of challenges these days with that ALS assessment and the documentation thereof. And this is something maybe as well that the committee could take up. Next slide, please. And then, of course, the next one of the other challenges we have is the burden of proof, of course, lies with the agencies with respect to getting from ALS1 to ALS2. And again, the patient care report must document all those interventions that are done to the patient, and only some specific interventions actually count. And so there's sometimes some question about whether or not we've included all the right interventions. Again, as quickly as these policies have developed over time and evolved, clinical practice has changed at 10 times the speed of the policy evolution. And so the reality is there may need to be some more clarification around what are those more high-level ALS interventions that should be included, because we're doing much more now at different levels than we were, you know, essentially when the original fee schedule was developed in the, around the turn of the century. Next slide, please. I alluded to this a little bit earlier. One of the key aspects of getting from ALS2 to SCT is the crew composition. And again, that becomes very much a scope of practice issue. And so we don't have a standard scope of practice around the country that allows us to sort of make that very clear for those of us who are trying to process these claims, code them properly, and get them out. And on the health plan side as well, these challenges that I've sort of run over the last couple of slides make it just as challenging on the processing side for health plans to make a good and consistent decision when it comes to how to pay these claims and which claims are appropriate to be paid at which level. So any work that we can do on clarifying these things and simplifying these gradations on the level of care would be welcome, I think, on both sides of the ledger to allow us to be more successful, more consistent in getting these claims paid. Next slide. So with that, my part of the commentary is done, and I appreciate the opportunity to present that information, and I will remain around to the end of the session for additional questions that you might have for me.
Thank you. Next up, we have Zach Gomer, who will present findings from MedPAC and GAO analysis.
Okay, great. Thank you all very much. Good afternoon. It's my pleasure and my honor to be here presenting at the GAPB. Glad to be on this great panel offering some independent information with both Ed and Lauren. I wish we were all in person, unfortunately. So my name is Zach Gomer. I'm a healthcare policy consultant with the Health Management Associates based in Washington, D.C. My areas of specialty include Medicare reimbursement systems, policy for Medicare and Medicaid, and data and analytics. Let's switch the slide, please. Okay. And as you can see from this slide, let's see, this is essentially a resume, but I have been with HMA for about 4 years. But prior to that, I spent roughly 16 years in government, working at MedPAC, the Medicare Payment Advisory Commission, for roughly 11 years, and then also the Government Accountability Office. Both of these are nonpartisan congressional support agencies. Most relevant to the GAPB, in my time at MedPAC, I was responsible for covering Medicare ambulance payment systems and generating reports on this subject. Several of the recommendations and findings we made on this topic have been implemented by CMS, including, most relevant to this conversation, cost report data collection from the industry, so that ambulance reimbursement rates could be based on more current data and more accurately pay for reimbursement. See, before diving in, I want to disclose that the American Ambulance Association is an organization that I do advise and have for several years. I do work for them on data analytics, and I think about CMS policymaking with them. However, today I'm here as an independent voice, not representing the American Ambulance Association. And I look forward to walking through this information with you, and I'm happy to take any questions at the end of this or afterwards if questions come up. Next slide, please. Okay. I was asked to participate today to speak to these 3 questions. To what extent do costs of providing ambulance transports vary by ambulance organization type? Did the MedPAC and the GAO studies of about 10 years ago suggest that patients were treated differently when it came to balance billing dependent on the organizational model that was involved? And third, what are the solutions that MedPAC and GAO recommended for better aligning Medicare reimbursement with costs? Okay, next slide, please. There are several studies here from GAO and MedPAC. I'm going to walk through them in chronological order, starting with GAO. And just to point this out, although I had worked at GAO in the past, these are not my studies. However, the MedPAC stuff we're talking about is mine. And I'm very, very aware of what the GAO studies are about, just having spent years essentially digesting them while at MedPAC. So we're going to walk through all of it here, and I'll point out some of the consistencies of these reports. The GAO generated 3 ambulance-related reports between 2002 and 2012. The first 2 GAO reports were very similar and built on one another. The first, in 2002, found that the data for this report was from 1997. The number of transports on ambulance entities, pardon me, let me go back for a quick second here. So in the 2002 report, these data used for the report were based on 1997 claims. The number of transports an ambulance entity conducted as one of their findings was a strong indicator of the variation and cost. This was a really important finding at the time. It had not been pointed out prior to that, but what this meant was that fewer trips equaled higher average costs per transport. And that's the theme that you're going to hear throughout this presentation. They also found that mileage or trip length had little impact on cost, and that this was more about readiness costs, or the vehicle and the building and the staffing costs. One important contribution here also that this 2002 study made was that they pointed out that population density has an impact on transport volume. And what this meant was that, again, fewer transports meant higher costs, and these transport volumes were going to be lower in low population density areas. Okay, let's flip to the next slide. Okay, in the 2007 report, the data for this report was based on 2003 claims data. This largely reinforced the low volume equals higher cost finding. But GAO added that ambulance entities tended to be those with higher costs tended to have higher shares of BLS services, fewer transports per year, more super rural transports, and had a higher percentage of revenues from local taxes. So there's some consistency between these two studies. Let's flip to the next slide. Overall, these two studies were very sound, reliable data. The main flaw with these studies was just that they were based on a small volume of a small sample of cases. However, these at the time were widely recognized as the best available information. Now the data are quite antiquated, 20 years old or plus. However, the findings of these studies are still very important and reflect some of the same situation that the industry finds itself in now. And again, the most important thing here is that both studies found that the volume determines the cost per case. And one more thing here, both also found that costs can be variable across the industry because there are so many different types of and sizes of ambulance entities. Okay, let's flip to slide 7, please. In 2012, the GAO revisited the ambulance industry for a report. They used newer data this time. However, it generated similar conclusions. This time around, they used 2010 data. And what they found was that the median cost per transport varied by geographic area that the ambulance entity served. And what you can see here on the slide above is that urban costs per transport were generally lower than the national median, and rural and super rural costs were higher than the national median. Higher costs were driven by the volume of transports the ambulance entity conducted, consistent with their past findings. Higher costs were also driven by entities having higher shares of emergency cases and higher levels of government subsidies. And I'll stop here for a second and point out that this finding that higher costs were associated with emergency transports is slightly different than what GAO reported in the past, which showed that there was a BLS association with costs. So now GAO has said emergency costs, emergency cases have higher costs, and that will be consistent from here on out in the different information that we're going to talk about. A couple of other important findings that came out of this GAO report. They reported to all of us that labor accounted for about 61% of costs, making up the majority of costs. They noted that there was wide variety or variation, in the margins reported by different ambulance entities. And maybe the most important finding here was that there was an inflection point for when transport volume resulted in higher costs. And what they determined was that at about 600 transports per year, ambulance entities' costs seemed to increase. So ambulance entities with less than 600 transports per year had higher costs than the rest of the industry. This was a novel finding at the time that has folks have since validated again. Let's jump to slide 8, please. Okay, so just to quickly summarize the last slide here on the 2012 report. One point about this here to caution is, again, this study was based on a small sample, and that's because this was survey information that was collected and the basis of the analysis. So that is one shortcoming, which we think we have a solution to in the next slide. So let's jump to slide 9, please. Okay, in 2013, the Medicare Payment Advisory Commission submitted a report to the Congress. This was the one that I was involved with. So this study is now 10 years old, but it came up with some recommendations that have been taken up by CMS and by Congress in the last few years. But we essentially arrived at a couple of different multi-part recommendations, one of which is more relevant to this organization than the other. But the first recommendation that we arrived at, the important part here was that the recommendation was that ambulance payment weights were based on cost data that were too old, and that the cost data needed to be updated, so that the relative values or the RVUs built into the payment system were based on weights from 1997 and needed to be updated. From that, this justified a finding that we collect cost data on ambulance, and that is something that is underway, as you all know, right now. The second recommendation was more around the use of BLS ambulance transport for dialysis treatment, and there's been a lot of activity in that regard, but it's not necessarily relevant at this moment to this conversation. Let's jump to the next slide, please. Okay. The MedPAC report contains several findings that I want to highlight here. The first, I've already mentioned in the recommendation. Again, maybe I should describe that the way the reports at MedPAC are structured is certain findings rise to the level of recommendation. Others are findings within the reports that often also get taken up by Congress or by CMS, depending upon need. But there were essentially 7 findings in the report that I want to highlight that are relevant here. First was the need to rebalance the weights using new cost data. The second is that there was potential fraud related to BLS dialysis transports. CMS has made policy to address that as well. We also found that ambulance costs varied widely across the industry. This was based on the variation also in entity size, as well as geographic location, as well as the nature of the organization, meaning nonprofit, for-profit, government, and their funding sources. We also found that cost reporting could potentially solve many of the problems that we're identifying. Using new cost data, add-on payments can be made more appropriate and better targeted, and also the weights can be corrected. We also found that, that we need to collect cost data. I just said that. Also, reinforcing some of GAO's findings, we reinforced that low volume entities have higher costs. And finally, we concluded here that zip code population density could be a better way to target add-on payments instead of urban, rural, and super rural classifications, because population density has a great impact on transport volume, and transport volume determines cost. Okay, let's jump to slide 11, please. Okay. I'm going to shift gears a little bit and now talk about some of the work that I'm doing at the moment for on the ambulance area. Most of this has centered around reimbursement and has touched on the balance billing issue. So in the last year and a half, I've been looking into comparing Fair Health commercial claims data with Medicare claims data to understand some of the variation that occurs nationally and on a subnational level. For those of you who don't know it, the Fair Health data is a commercial claims data set made up of several different payers' claims data, essentially. It consists of about 20 million claims. I was using this data set to compare it to Medicare claims, which amount to roughly about 10 million claims. And this work has mainly been centered on looking at the commercial rates or allowed amounts and charges relative to Medicare allowed amounts and charges, and how that varies by state, urban and rural area, and then also by transport type. I think we can jump to the next slide. Let's see. Yes. And I'll just say one more thing here, which is that about that last slide, actually, which is that our main findings of this work with Fair Health, comparing it to Medicare, is that commercial charges and allowed amounts vary widely by state, urban and rural area, and by transport type. We see different rates all across the board, and it's hard to generalize exactly what these rates will be in all areas. We also found that median commercial allowed amounts are consistently higher than Medicare allowed amounts, but there is that great variation. And then this chart right here on the screen, what we've done is to try to depict a little bit what these different, what the variation looks like from state and within the different transport types. And what you can see is that there is relative chaos to the measure of the median commercial amounts relative to Medicare allowed amounts. And I'll just start on the top line here and describe that for you. But for ALS services, what we see is that commercial amounts are 250% of Medicare or more in states such as Texas, California, Hawaii, North Dakota, and Utah, and Minnesota. At the other end of the spectrum, in Maryland and Maine and other states, you can see that commercial rates are more consistent with Medicare rates. So there's wide variation within the ALS emergency category. Some of the states have much higher commercial rates, nearing 300% of Medicare. Others have rates that are more comparable to what Medicare is offering, and that's on the left side of the screen. But you can also see that the story is completely different for a different type of transport. On the BLS transport level, there's greater variability. And you can see that just by seeing that there's more states on the far right. States are also at either end of the spectrum are different than what we saw in the ALS transports. And what I mean by that is on the BLS row, what you can see is that there are a different set of states, Washington, Alaska, Illinois, Oregon, on the far right, on the high end of the spectrum. And you've got other states mixed into different categories here. So there is wide variation. And there's just a couple of other points about this analysis. What we did find, and I didn't try to depict it here, was that when you look at urban and rural areas within states, the variation becomes even wider. And it's not specifically higher in urban or in rural areas in a given state or across states. It really is area to area dependent. And it's hard to kind of draw a trend across the urban and rural areas. The second thing that I want to highlight here about this analysis was that when we looked at 2019 and 2021 data, what we saw is that commercial payments declined relative to Medicare just slightly. This suggests that commercial payers may be increasing pressure on ambulance entities slightly in the last couple of years. Let's jump to the next slide, please. Okay, a couple of other points about data work in the last couple of years, points that might be helpful for this organization. In some other work that we've done, we've recently shown that ambulant cost centers are a dynamic area, but we do see that labor remains the biggest component of cost. Fuel is highly variable within a given year even, and this is an area of costs that the industry cares deeply about and watches like a hawk. And that we've noticed that the cost of supplies has increased in recent years. Things like drugs, medical devices, and other items and services built into the payment system have increased over time. And I say built into the payment systems, built into payment generally. They're not specifically built into the Medicare payment system, but these supply costs have increased. And I think this is an area of concern going forward for the industry and for CMS potentially as it tries to set rates. We also see that supplier and provider types have become more complex in the last 10 years. It used to be that there were 5 or 6 different types of ambulance types to worry about. What I mean by that is nonprofit, for-profit, government, fire. There seems to be more chaos in this area. There are different types of mixed types, I would say, of ambulance entities out there to factor into this. And I think it makes the environment more complex. In addition, there's been some change in kind of the pandemic era. We've seen non-emergency transports decline in the last couple of years. We've seen interfacility transports decline in the last couple of years. But one thing that has not really changed is that smaller ambulance entities continue to dominate the industry. Specifically, we count that about 75% of the industry consists of entities that have 800 or fewer transports per year. In addition, super rural entities consist of about 20% of the industry overall. That's not changed as much. Okay, I think we're on to the next slide, and it may be my last couple here. So I just want to summarize quickly some of the things that I've talked about and bring us back to the questions that were posed at the very beginning. So to what extent do costs for providing ambulance transports vary by ambulance organization type? And what we've said is that, and what independent studies have shown, is that higher costs per transport are associated with lower volume ambulance entities entities with higher shares of emergency transports, geographically isolated areas, as well as entities that have high levels of government subsidy. We've also, actually, we're going to jump now, I think, to the next question. I'm sorry, please go back one more. All right, yes. The second question, important to this especially, is did MedPAC and GAO studies suggest that patients were treated differently when it came to balance billing, dependent on the organizational model that responded? And unfortunately, neither the MedPAC nor GAO findings spoke to balance billing specifically. I think information that I provided on variation in commercial and Medicare payment amounts is more relevant to the balance billing discussion, but MedPAC and GAO did not get into that area at that time. Next slide, please. Okay, question 3 was, what were the solutions that MedPAC and GAO recommended for better aligning Medicare payment with cost? The first couple of things I would highlight here are about BLS dialysis transports. That was a big focal point, which CMS has implemented policy to deal with. Rebasing the RVU weights was a very important finding that MedPAC came up with and is potentially being solved right now through the collection of cost data. And hopefully that cost data will be robust and have the ability to set RVU weights appropriately and more current than 1997. We also found that better targeting add-on policies to support low volume entities in isolated areas is a good direction to head. And that, again, we offered the idea that cost report data should be collected. Sorry to reiterate that one more time. I'll stop there and happy to take questions at the end of the panel or whenever folks have questions.
Thank you. Next up, we have Lauren Adler, who will present on ground ambulance patient payment and billing for the commercially insured.
Sure. Hi. Hi, everyone. Thanks for having me again. It's good to see everyone. I'm excited to be here. So I'm for those who didn't get the introduction at the beginning of the day, 8 hours ago or whenever that was. I am a health economist at the Brookings Institution in Washington, D.C. We are a nonpartisan research institution. Do a lot of research that's kind of similar to your standard academic institution. And I've done a lot of work on sort of surprise billing generally. And today I'm going to be presenting analysis from a paper I published in Health Affairs in January. The journal was nice enough to time to the initial meeting when this was planned in January. And then, but I'm happy to be able to present that data now. So if you can move to the next slide. So this is all work that I did with colleagues at both at Brookings and the University of Southern California. And it is some sort of overlook data at the ground ambulance market nationally, and then some data where we are kind of drilling down by the ownership structure of the ambulance organization, focusing one on just sort of the private versus public sector ownerships, and then within private sector, looking a little bit at whether there are any differences we observe for those organizations owned by a private equity or previously publicly traded companies here. So if so actually to clarify, right, I think I mentioned this in the chat earlier, but basically this paper all uses data from what's called the Healthcare Costs Institute, which compiles insurance claims from United, Aetna, and Humana, or at least the version of the data we did. So it's got all of the sort of commercial claims from those payers. It's just those payers, so it's inevitably not necessarily representative of the full market, but those are three of the largest payers, so should give us some picture into how things look at a national level. And you'll hear a lot of themes that folks have sort of brought up, including Zach most recently. If you could move to the next slide here. I think it's worth kind of laying the groundwork a little bit here, right? I think folks have talked about a lot today that the market dynamics for ground ambulance services are just really unlike pretty much every medical service that we think of, right? It is ambulances tip for, when we're talking about emergency transports here, pretty much have to pick up any patient without regard for ability to pay. And at the same time, right, there's no the sort of standard insurer ability or employer ability to kind of like steer care to a preferred provider also doesn't really exist, right? Often for emergency care, there's a monopoly provider in the local area, and you know the patient needs the care now. You know, the only real sort of negotiation we have is sort of this post hoc negotiation after the fact, where there's just this game of, you know, how much is the insurer going to pay? Are they going to send the check to the patient and make the ambulance collect? All of these sort of games that are not really how we think of a traditional market working here. And I think it's also worth noting here, I think some other folks mentioned here as well, this really is an industry with a lot of small providers. There's one very large national company, American Medical Response, who's about 10% of the national market. And beyond that, at least in the data we looked at, there's only 2 other companies who are even more than 1% of the national market, and barely so. And that's Acadian, with sort of Southeast regional focus, and then Falk, another one of the private equity backed companies here. So this slide here, right, I think is sort of overarching. I think some of these numbers came up in one of the earlier presentations today. But basically, right, in the data we see that 85% of emergency transports from 2014 to 2017 were billed on an out-of-network basis. Interestingly, about 2/3 of those were actually allowed in full by the insurance company. So that means the insurer set the allowed amount equal to the provider's billed charges. So therefore, there is no actual balance bill in that situation. And in that case, but that still leaves 28% of the time. So 28% of emergency transports where the patient is potentially liable for a balance bill. And on average, those were $530. I think folks earlier mentioned it's very hard to know when the balance bill is actually sent to the patient, right? What we can observe in this sort of data is only when the patient is sort of is liable for that. In some instances, the provider or the sort of the ambulance organization in this situation may not actually send that balance bill. I've not seen any really good data on this. Texas recently released survey data of ambulance organizations in their state that estimated that about 77% of Texas ambulance organizations, including sort of the public sector ones, indicated that they do send balance bills when the insurer is not paying in full. But again, that's one state, so I don't know how much that can really kind of guide your national perspective. And then the other point here, which I found interesting and a little bit jarring, is that 57% of non-emergency transports were also out of network. And sort of a similar dynamic where often the insurer is allowing the full amount. But even in cases where there is this potential difference between what the insurer allows and what the provider, the organization's billed charges is, there's 26% of the time that there was a potential balance bill. And in these cases, on average, $620. Next slide, please. So I'll jump through this quickly, but this slide is, I think, probably actually hard to interpret during a quick presentation here. But the idea here is just trying to show, so we tried to look at what prices look like, or what the prices that insurers are paying for ambulance services in urban versus rural areas versus super rural areas, all relative to Medicare and sort of the distribution thereof. And then again, both for emergency advanced life support level 1, which is sort of the most commonly billed code, and then for emergency basic life support. What you can see is sort of across the board, the payments for ALS services tend to be higher relative to Medicare, and you also tend to see that the payment rates tend to be higher relative to Medicare in urban areas than in rural areas. And of important note here, we are using sort of the Medicare rate here encompasses all of these add-on payments that we've been talking about. So, right, the rural Medicare payment is 50% higher than the urban Medicare payment is. So this sort of shows that the sort of Medicare being more generous to rural ambulance services does not appear to be fully reflected in the commercial insurance market, probably as expected. Next slide, please. And this, I think, gets to a point that a lot of people have raised here, is that it's just, things really vary a lot across the country in terms of what commercial insurers are doing here and sort of how much, the sort of allowed amounts that they are sort of sending out for these services. I think very interestingly, so we did a lot to try to standardize what was happening. So we're basically looking at, this was sort of the price for an average distance transport. So we sort of took every transport, took the per mile rate and then said, okay, here's what it would be if it was, 8 miles on average for an urban transport. And then we're going to compare that to Medicare. As you can see, about 40% of emergency ambulance claims here for ALS we're basically paid almost exactly at the Medicare rate. But there is the top 20% there. Right now you're looking at, top 30% actually, are being paid more than 2 times Medicare. So there is this very wide variation, and not always that easy to nail down exactly why the variation is happening. And I think to points that were brought up earlier, I think some of this is just sort of payer specific policies or kind of sometimes even employer specific policies here, because often these are self-funded employer plans where the employer is often making kind of the final decision here. Next slide, please. And again here, this is sort of making the point. I think Zach touched on some of this in the last presentation. This is kind of calculating just here is what the median allowed amount is relative to Medicare in each state. And again, it is in 17 states, the median rate is very close to Medicare. It's between 1 and 1.1 times the Medicare rate. However, it's over twice the Medicare rate in 10 states and over 3 times the Medicare rate in 4 states. Interestingly, I think, different data sources here, but we did find pretty, the rates relative to Medicare tend to be lower for emergency basic life support, but you do see pretty similar trends in terms of, kind of where the high rates are, at least in the sort of United, Aetna, and Humana data that we are looking at here. Next slide, please. All right, so now I'm going to go into this sort of breakdown by ownership structure that I was sort of teasing at the beginning here. Next slide, please. So this is just sort of an overhaul here. I don't think you need to look at the numbers here. The basic idea is most of the services that we see in the commercial market are advanced life support level 1 emergency claims. So the A0427. And then within non-emergency, we mostly are looking actually at the basic life support claims. And in our data, roughly 10% of emergency claims were billed by private equity or publicly traded ground ambulance organizations. About 60% were billed by the public sector. That is a very big difference in the ground ambulance industry compared to sort of pretty much the rest of healthcare. And you'll notice that the public sector is much less involved in non-emergency services, as you would expect. They still are providing about 10% of the non-emergency transports, but that's far less than the sort of 60% that they're providing of the emergency transports here. Next slide, please. All right, so this question came up a little bit earlier in terms of how often are different ownership structures of ground ambulance organizations out of network. So this looks at basically, we're looking at, the leftmost bar here is, okay, let's just combine all ground ambulance organizations together. And then, here is the private equity or publicly traded ground ambulance organizations. Then here's sort of the rest of the private sector. And then that rightmost bar in each part of each panel of the graph is the public sector. I think interestingly, the public sector actually, in our data at least, was out of network the most commonly. So 93% of public sector claims were billed on an out of network basis. My understanding, and other people here probably know better than I do, a lot of times there just really isn't even an attempt at a negotiation with the sort of public sector ambulance organizations. And they also aren't providing any of the non-emergency transports, where sometimes there seem to be deals where it's sort of based on, there is some market for the non-emergency transports, but we don't see that, for public sector is doing pretty much all emergency. But again, right, so it's even more. So about 70% of the time, the insurer is allowing the full public sector's charge. So their full bill of charges, they're allowing that in full. So basically at the end of the day, you're actually at a pretty similar risk of being liable for a potential surprise bill, kind of regardless of the ownership structure of the ambulance, actually slightly less for the private equity backed carriers here. Next slide, please. So this is it. So now we are comparing what your average patient cost sharing liability is and what the magnitude of a potential surprise bill might be across these different ownership structures. This is where you start seeing, I think, pretty big differences jump out between the private and public sector here. So, by the end, we are seeing, right, if you just compare, it's actually not quite on here because you have to combine the sort of private equity and other private sector into one here. But in 2017, we see cost sharing for, this is an advanced life support level 1 emergency transport. We see average cost sharing of $260 for a private sector ambulance, which is about 25% higher than we see on average for a public sector transport. And the difference is a little starker even for balance bills, where it's about $735 is your kind of average balance bill if you're picked up by a private sector ambulance, and that's 50% higher than the $480 or $483 that your potential balance bill might be if you're picked up by a public sector ambulance. Next slide, please. And you'll see basically the same dynamic. So now, rather than looking at cost sharing and potential surprise bills, we're looking at, these are the sort of prices paid by commercial insurers, and then also the charges, the sort of bill charges by the ambulance organizations. This is, you're going to see again right here where we see a very similar dynamic where the prices and charges are 35 and 38% higher respectively for private sector ambulances compared to public sector ambulances. And when you look at this sort of price comparison, now you see a little bit more difference between the private equity owned ambulance organizations and the other private sector ambulance organizations. Although, this is like a 12% difference. I will note that is a notably smaller difference than we see in, say, the air ambulance industry or the emergency medicine doctors there. So, but I think that has a lot to do with, as folks have said here, that there is a lot of local rate regulation out there. So there often isn't that much sort of kind of monkeying around that can even be done on the sort of charge side of the coin here. Next slide, please. So some quick takeaways here that I sort of wanted to leave folks with. Right, that data is pretty high level, and I think people in the chat are correct. Obviously, there are clear differences between the public and private sector here, but I think some of these differences do weigh on some of the considerations that the committee is charged with here. So one, obviously, most transports are out of network. That is, potential surprise bills are very common, even for non-emergency transports. It is still notable that we see higher prices, higher cost sharing, and higher potential surprise bills for private sector versus relative to public sector ambulances. I also found it interesting that rural ambulances tend to get paid less relative to Medicare than urban ambulances. And as many have pointed out, there is just very wide variation in pricing and often without a very clear justification for sort of when things are varying. And next slide, and the last slide. So some policy implications I just wanted to touch on. I think I'm giving another presentation tomorrow that's more focused on the sort of policy options before folks and before Congress. But I think some of the clear takeaways from this work are, one, to me at least, this suggests that patient protections may be needed both for emergency and also for non-emergency transports, given how frequently non-emergency transports are delivered out of network. I think as one of the ambulance organization folks mentioned earlier, in-network prices here are unlikely to be a reliable guide either for arbitrators or for any sort of payment mechanism that one might come up with here. Right, there just are not many in-network prices, and to the extent there are, They are just not determined by any kind of normal market negotiation that we might think of. So it's hard to imagine they are terribly representative of anything we want to recreate. I think also, right, focusing on local market prices could enshrine inequitable payments going forward. I think one interesting thing that we've talked about here is sort of any focus on kind of, any sort of payment mechanism that, is local specific based on kind of existing prices would effectively penalize areas that have, say, subsidized their service so that they're only charging Medicare rates. And it would effectively, reward insurers who are only paying Medicare out of network, because now, the payment in those areas would be low going forward. So it sort of rewards almost the opposite of what you'd want, which I think leads you to sort of, it leads you towards the idea of kind of setting something more as some multiple of Medicare prices, or something that is set more nationally, plus some adjustments for, local wage indexes and that sort of thing. And then lastly, just to close, right, because Medicare payments they do differ by, they pay more for ambulances in rural areas. Setting prices based on sort of a multiple of Medicare would be relatively more generous to rural and also to public sector ambulances, who tend to get lower allowed amounts today than the sort of nationwide average might be. And on that, I'll close, and I'm happy to take questions as well as everyone else here.
Thank you. At this time, I will turn it back over to Asbel for committee and public feedback.
All right, well, that was a lot of information. And I know with me, I have lots of questions because I love data. So lots of questions, I'm sure, for Zach and for Lauren. However, committee members, if you've got questions, we have about 20 minutes here before we will end for the day. It's hard to believe. It's been almost 8 hours, as Lauren indicated. But if you have questions, if you will start raising your hands, we will try to get to them as possible. I'll start with Gary Wingrove.
Hey, thanks for those presentations. Asbel, I'm kind of noticing some terms being used as if they are the same thing. And at some point we might need to have some definitions. And the terms that I'm hearing as kind of meaning the same thing are price, charge, cost. So for example, the cost, the big cost of a volunteer ambulance service is being borne. The biggest cost is labor, just like it is anywhere. That cost is being borne by people. And it's not going to show up in a document that goes to Medicare that says, what were your expenses last year? Unless there's a concerted effort by Medicare to say, here's the minimum. If your costs are below that, you're done because you've already met the minimum, and our minimum is everybody gets a paycheck. That's what our minimum should be. But I just see that kind of thrown out. So I'm really curious, Zach, you spent some time at MedPAC. I used to follow MedPAC. I went to a couple of meetings over there. I'd like to ask the question of you that I asked of Lauren this morning. In the work that you did at MedPAC, you dealt with hospitals, clinics, home health agencies, a wide array of providers, I'm sure. So what percentage of those providers that exist in rural or super rural areas would you say the professional workforce component are the costs being borne by volunteers? What percentage of the workforce of any hospital, clinic, home health agency, other provider of care, are they expected to be volunteer professionals?
Yeah, happy to take the question. Thank you, Gary. I'm sorry you had to sit through MedPAC meetings. That probably is time you want back. Let's see. So your question is a good one. So on one of the slides that I put up, I showed that about 60%, maybe 62% of costs were associated with labor that we had found in some of our more recent research. of data here, but that's generally consistent with what you see in the hospital world, where hospital reimbursement uses a wage or labor adjustment of roughly 65%. It kind of varies, but that's about what it is. So it's a little bit less. It seems labor is a little bit smaller share in the ambulance world, but to your point, than hospital, I would say. But to your point, a smaller share of the labor in the hospital world is attributable to volunteer. Candy stripers do not make up a large share of the workforce in hospitals. So your point is well taken. I think I'm safe to say volunteers make up a larger share of the labor force in the ambulance world, but it does vary by ambulance entity significantly. Some have none, and some have all volunteer.
Right, and I won't belabor this, but my point was the professional workforce. We don't have need for candy stripers in ambulances either, but we do have medical professionals working in ambulances. And why are we not expecting doctors, nurses, physical therapists, occupational therapists, and other professions to be volunteers in their chosen profession? But we do. Somehow it's acceptable for our payment system to not recognize professionals who, quite frankly, make the decision about whether you're going to live or die when you're in their care. We devalue on the ambulance side, and cost is cost. And just because in dollars and cents it doesn't go out of the checkbook, there is everybody's got the same cost. An ambulance costs what an ambulance station to operate costs what an ambulance station to operate. It's how much volume you have to pay for it, which is where your price point gets set. And Asbel, that's why I'm saying we're mixing up terms, because we're talking cost, we're talking price, we're talking charge, and they're not the same thing, but they sort of sound like the same thing.
And I've noted that for the record, Gary, as well. I know Dr. Shaheen and I have noted that for the record, that when we start moving into the subcommittees on this, terms and definitions are going to be really, really important. Excellent. Any follow-up to that? I see Rhonda, and I don't mean to push it along, but I know we've got about 13 minutes here. And so I want to make sure we get to all the questions. Thank you for that, Gary. Rhonda?
Yes, I just have a quick question. I was noticing in some of Zach's slides and also earlier today, whenever you put up a map of the states with data, it looks like Idaho, Montana, the Dakotas, maybe Wyoming, no data available.
Zach, would you like to comment on that?
Sure. Yeah, absolutely. So I think you might be confusing Lauren's slides and mine a little bit. We used a data set, Fair Health, that did include some claims for those states that you mentioned. So we did have some of that in there, but that's going to be dependent upon whether or not there were insurers in those states that are contributing to the data sets that would be used. And I think Lauren and I used different data sets, both very good, both reliable. But I don't know, Lauren, if you want to speak to the maps. She referenced the map.
Yeah, I mean, the point was basically, the data, the HCCI, sorry, the Healthcare Cost Institute data had insufficient, did not have enough transports to report data in those states. Basically, to report any state-specific data, there need to be at least 11 different beneficiaries who were transported in that state in a year. And just, I mean, it means in the data, there just weren't that many people there. So that's why, obviously there are ambulances in those states, but you'll know those tend to be less populous states.
Very rural areas. So I was just kind of curious, but thank you.
And dominated by blue plans, at least in general.
That's a good point, Lauren, because that'll follow up to my question, because I don't think some of the individuals on the committee may know, as well as the public listening. The HCCI data set that you used, explain the insurance carriers that are reporting to that data set and the ones that are not. That might help them understand that context.
Yeah, sorry. So it's United Healthcare, who's the biggest insurer, and then Aetna and Humana. So it's only those three carriers. It's a little confusing because they have like since updated their data and now have a slightly different collection of carriers, but it does not, importantly, does not include the Blue Cross plans, who in those states we're talking about here, maybe not all, but a lot of them tend to dominate and sort of dominate a lot of the rural states.
And this relevant data set was from 2016 to 2017, if I saw your slides correctly. Is that correct? Okay.
Correct. So the data is
That was
getting a
a
little
very
bit
good question, Rhonda, as well.
Thank you so much.
You bet. Sean?
Thank you. Excuse me. Question for Lauren on some of your sort of conclusion leading to the methodology that may or may not benefit public entity or whatever. I can't remember how you phrased it. I apologize. But did you look at in those locally regulated rates, how that rate determination was factored in and whether it was related to cost specifically? Was cost data provided in setting the locally regulated rate? And then correspondingly, was there subsidy provided within that system to achieve a locally regulated rate that may be high, may be low, whatever, because it was operated by a subsidized versus an unsubsidized entity?
So we've like tried to do anecdotal versions of this, but weren't able to build anything comprehensive just because the sort of data on local rate setting is very hard to piece together a full national picture on. But I mean, certainly you are correct that like their public sector agencies are more likely to have subsidies that are kind of feeding some. I mean, certainly in DC area, the DC government in Montgomery County near here, right, they're charging Medicare. Right, at least DC is, right. So that's like a very clear, there's kind of a subsidy that's going into that. But that actually, right, that feeds into a little bit more the point that the sort of conclusion point, which I don't mean to be as sort of a hard and fast conclusion, but right, if ambulances, if they're only collecting Medicare in DC, because that's sort of the rate setting here, and all of a sudden you set a national standard that said everyone has to pay 2 times Medicare, right, that is like a big boon to the DC government. Right, so it is sort of more beneficial to the sort of public sector ambulances on average, right, there's always going to be variation here, than, if there was private sector ones who, were getting paid 3 times Medicare before, for instance.
I see. And Asbel, if I could ask just one follow-up.
Sure.
And that's just around the mileage and the average mileage or average distance, I think. And did it take into account, some of the interfacility balance bills, maybe because of large mileage components from rural to urban centers with a major medical center, for example?
I mean, so that definitely can be a part of why the non-emergency balance bills tended to be larger. We focused our analysis primarily on the emergency side of things, but you're right. So the emergency transports are almost always like scene of accident to a hospital or home to the hospital, whereas the non-emergency transports are almost all interfacility or maybe home to a nursing home or something along those lines. So no, I don't have the mileage off the top of my head, but the average mileage, for instance, is certainly higher in rural areas than in urban areas, as you would, and even higher in super rural areas as well, as you would expect.
Perfect. All right, Patricia, I know you've been waiting patiently there.
No worries. I'm trying to still stay focused right up to the very end here. But I did have a question. I think it was for Ed. I appreciated the description between ALS 1 and 2 and things, but I was I just would like clarification a little bit more on this ultimate clinical finding. Is that determined by the paramedic or whatever in the ambulance, or is that defined like once they hand off the patient to the hospital? Can you just tell me a little bit more about that? And then I do have one follow-up question as well.
Yeah, so what I was referring to in the ultimate clinical finding is it's retrospective and it's done by the payer. And so they'll look at what the documentation is on the transport record and make a determination that may be different in retrospect, again, hindsight being 2020, to what the crews saw and were concerned about at the time that they were caring for the patient.
Thank you. That helps. And then I don't know if this is for you, Ed, or somebody else who can answer this, but I do have a patient who who has contacted me who has their ambulance bill, but then they got a separate bill from the healthcare like professional, the doctor or somebody who did a ride along. So what's that all about? Is that a common practice? Is that legal? Who would be covering that? How would that be paid? Can you explain that? This would somebody in the commercial market.
Yeah, it's generally not a common practice, but there are professional service fees. For example, in the emergency department, emergency physicians billed differently from the facility that operates the, with the nurses and the heat and light and all that stuff. And professional fees can be billed just like when you're in the hospital and you call, you have to call a GI physician to come in and consult. You get a separate bill from the GI physician group. There are some entities that will bill a professional fee for an emergency physician, for example, for medical oversight. It's not as common as you would think, but it does happen occasionally. I don't know if that's the case that you're talking about, if that's what happened here, but it could be the case.
Okay, so I think we should just put like a pin in that because especially, we have to get clarity, like would the No Surprises Act cover that if that was an out-of-network physician? Yeah, so thank you. Thanks for that.
For that, Pete, I see your hand is raised.
Yeah, to answer that question about the person riding along, the majority of the time that I'm familiar with it and in my experience with billing, that is going to be an interfacility where somebody from the hospital jumps on board an ambulance to go to the new facility because
that's what it was.
Yes, and so that's the case. It's not an emergency transport, but this is an individual where the only ambulance available may have been a BLS ambulance. So the BLS ambulance shows up at the hospital to get the patient to the next facility, and somebody from the facility, the hospital itself, has to jump on that ambulance to get patient A to the second facility because there's no other level of care that can monitor the level of care that's being provided to them, either based on medications administered or based on the diagnostic equipment or the support equipment. So those are situations that is a critical care transport, but because they're two separate entities, the ambulance company doesn't get billed for the critical care transport, doesn't get reimbursed for it. They get reimbursed for a BLS, non-emergency transport in some cases. And then the individual provider has to bill, but those are normally in rural areas where there is no CCT, critical care transport ambulance available.
And so I think this brings again the complexity that goes on within the EMS space, Patricia, that you're seeing as well, and the explanations that you're hearing. It could be numerous entities, and also in the comments, you're getting a lot of different comments on it. Could be this, it could be that. So we'll continue to explore that over the next several months as we put together some recommendations regarding these complexities and how we can keep that patient out of the middle as well. I'm going to have one public comment before I turn it back over to Tara to do some wrap up as we move into tomorrow. But there was one comment that came out, and this is specifically for you, Lauren, that was asking predominantly if the blues are not included in the data analysis that you did. Is there a reason around that you're aware of why the blues aren't participating in the data sets that you're using?
Sure, I was just typing that into the chat as you spoke, but to bring it out to the fuller group here. Basically, the Healthcare Costs Institute is just a nonprofit that convinced insurers to be nice and give them data effectively. So they used to only have data from United, Aetna, and Humana. Actually, what's sort of interesting is, well, annoying for my sort of, United eventually backed out, and United does not provide any new data past 2017. And they actually since, so there is a new version of this data that does have the Blue Cross data, although not Elevance or the Elevance Anthem, but the rest of the Blue Cross plans does have that data in place of United. So I do have plans to sort of redo some of this analysis with that, and then you'll have data for Arkansas and for Idaho and Alabama and a number of these states where there's sort of a dominant blue plan here. But unfortunately, I think is not something that's immediately ready, unfortunately.
So I had two questions, and that one of them we must have had mental telepathy because you answered it. I was going to ask you if Brookings was working on an updated version from the 2016, 2017, and you pretty much answer that, indicating that you guys are working on that. And then Zach, I had a second follow-up question for you regarding fair health data. Similar to my question for Lauren and the data sets that are being used there, you spewed out a lot of data from Fair Health. Can you tell me where the sources are coming from Fair Health data?
Oh, yeah. Let's see. I'm going to have to go back and get the names of the organizations that have contributed, but generally the comparison is Fair Health tends to be larger at this point in time. It varies from year to year, but in 2021 and 2022, Fair Health tends to have a larger mix of insurers in their bucket. It's put together much like what Lauren described with the HCCI data. But I will get you a list of the folks that are the insurers that are in there. Sorry.
I think that would be, unless you know that, Lauren, that would be beneficial.
We had tried to work with Fair Health data, are maybe not the biggest fans of the data quality, but that's a separate, they generally will not, I think they're pretty strict on, they will not tell you who the contributors are. People theorize that it's the Blues, but then I've talked to people who have Blues plans who claim it's not them. So I've never gotten a straight answer to that, but it would certainly be great if they've changed the policy on that. I have not worked with this in a few years, so things could have changed.
So there might be some confusion around that. 2016, 2017 data, Lauren, was what your study used. And Zach, can you tell me what study your survey was using? What's the data range?
Yep, we've done this a couple of times. We did it with 2019 data last year, and this past year we did it with, or more recently, we did it with 2021 partial year data. And we're going to try to do it again later, maybe early this summer, with half 21 and half 22 data. Yeah, and the reason we're doing that is we're trying to match it with what's available with Medicare. We've got 100% Medicare claims data up through 2022, but we're trying to match the two, and that's also another added wrinkle. True to what Lauren said, Fair Health is persnickety about their stuff. So anyway.
Right. Well, I appreciate it, guys. I know we're 4 minutes over. I'm going to turn this over to Tara. There's lots of great questions coming in here. Some of you guys have got some questions. If we can fit it in tomorrow, we will ascertain those questions and try to get to them as well. But I'll turn this back over to Shaheen and Tara to close us out, and look forward to seeing y'all tomorrow.
Thank you. We will resume tomorrow at 9:30 a.m. Eastern Time with day 2. We would like to express our thanks and appreciation for the time and dedication given by today's presenters. This concludes today's meeting. Thank you and have a wonderful evening.